Hello friends. So now we are discussing forensic medicine and toxicology, FMT. Recall INI CET for FMT, forensic medicine and toxicology. FMT. Now the paper level, anyone tell me, what was the level of paper? Anyone? What was the level of paper? Hello everyone, hello. What was the level of paper? Moderate, tough, easy, anyone? Is it eco? Now the sound is okay? Now the sound is okay? Hello everyone, hello. Yes, your sound is echoing. Now the level of sound is okay? Moderately tough. Okay, now it's okay. Okay. So moderately tough. Yes, okay. So we can start now. Now these all are the questions based on the recall. I'm coming to question one by one. Listen question very, very carefully. A girl from village was found dead in a lab, was taken out. In the case of antemortem drowning, all are true except. Friends, I'm highlighting this except. Means which is not true for antemortem drowning, which is not true for antemortem drowning. Okay, now see. First question, first option, water in a stomach. Water in stomach, it is true. Because whenever the body is drowned, the water goes inside the stomach. This is true. Okay, this is the first one. Second, fraud on the nose and mouth. Which kind of frothing is seen? Anyone can tell me? From the nose and mouth, which kind of frothing is seen? Yes, anyone? It's the white mucoid frothing. It's the white mucoid frothing, leathery frothing that is seen. So it is also true. Now, washerwoman, washerman, hand and finger. Friends, washerman, hand and finger, this is non-specific finding of drowning. This is non-specific finding of drowning. What is the meaning of non-specific finding? This can be seen in antemortem drowning as well as postmortem drowning. So this is not correct about the antemortem drowning. Now, this diatom test is positive. This is true. Diatom is unicellular algae present in your body along with the water. Diatom test is positive. Cadaveric spasm in hand of muscles. This is also true of antemortem drowning. So what is not correct of antemortem drowning? That is washerwoman hand. Yes, my dear friend. Washerwoman hand or finger or washerwoman. This one. Now listen very, very carefully because this question I also discussed in this last INI CET, this picture-based session as well as in one liner. Okay, so this is a very, very important one. Washerwoman hand, washerwoman soul. These are non-specific. These can be seen in antemortem as well as postmortem drowning. As you can see the picture, sir, this is cadaveric spasm. This is the most characteristic finding of antemortem drowning. Cadaveric spasm. Is it clear, sir? Second, drowning. This is specific one. As I told you, the frothing from the drowning, the frothing which is white, leathery, copious, mucoid frothing, this is characteristic. So anyway, simple one. What's the answer here? Tell me. It is washerwoman hand and finger are not characteristic of antemortem drowning. Is it clear, sir? Here, how many questions were from forensic medicine in your exam? Anyone? How many questions were from forensic medicine? Anyone? Hello everyone. Hello. Hello boy. Hello. Kitna question tha forensic medicine? Anyone? Yes. Almost. How many questions? Yes, there were almost 10 to 12 questions from forensic medicine. Okay, now I'm coming to the question number 2. Now, if female was given morphine sulfate during labor for pain and she developed respiratory distress, respiratory distress, which of the following is correct antidote? A very, very simple MCQ. And my dear friend, this I discussed in one liner this time. Very, very simple. For opium products, we give naloxone. For opium product, we give naloxone. So you can see these are the antidote. Paracetamol, I discussed this in one liner in the last session. Paracetamol, we give N-acetylcysteine. Methanol, which is a better antidote for methanol, it is ethanol. For carbon monoxide, we give hyperbaric oxygen. This is my favorite MCQ. Benzodiazepine, we give flumazine. Yes, this was a question. For opiate, we give naloxone. Organophosphate, we give atropine and oxime. Cyanide, we give amyl nitrite, sodium nitrite, and sodium thiosulfate. Just keep these two things in your mind. Helium, we give Prussian blue. Yes, there was one option, water in stomach. I discussed that option. Okay. And methemoglobinemia, we give methylene. So just remember, this is a very simple MCQ. The antidote of choice for all opium product. This opium product could be morphine, heroin, anesthetic, any product. That antidote of choice is naloxone. The answer is naloxone. Yes, dear. There was one option, water in stomach. Now I'm coming to the question number 3. As clear-cut question from the notes. You can see the Blackfoot disease and peripheral neuropathy. Yes, Blackfoot disease and peripheral neuropathy is seen in which metallic poisoning? Very, very simple question. Anyone, you will answer. Very simple question. Blackfoot disease. Because it causes vascular ischemia. The answer is arsenic. I have taken the screenshot of my notes. Yes, my dear friend. This is arsenic neuropathy. My dear friend. Sensory is more common if we compare. Sensory is more common than motor. And you can see this is Blackfoot disease and peripheral ischemia. This is seen in arsenic poisoning. So third question, which is very, very simple one, the answer is arsenic poisoning. Is it clear, sir? 3 questions solve okay? मेरे ख्याल से forensic paper was little bit like moderately tough, or I would say the tough and easy beach wala. That would be for this one. Voice echo is there. Voice echo is there still. Okay, dear. Blackfoot disease with peripheral neuropathy, it is seen in arsenic metal poisoning. Simple question. Yes, simple. Now the first question, I see, which of the following substance is bitter in taste? Simple question. Which of the following is bitter in the taste? Anyway, it's very simple, sir. There was hydrogen ion, no bitter in taste. Amino acid, the glutamate was given an option, or amino acid was given. Yes, very, very simple. Aldehyde is not bitter in taste. It is alkaloid. Is a thing which is bitter in taste. And we all know, my dear friend, the plant alkaloid, the plant seed are bitter in taste because of the alkaloid. Very, very simple question. So this was question number 4. Now, incorrect about the postmortem finding. I think this was like something which is a tricky question. Thoda sa tricky laga mere ko. Now, first option, cadaveric spasm is seen in specific group of muscle. Cadaveric spasm occurs in the specific group of muscle. Echo aa raha hai? Getting echo? Yes. Echo abhi bhi aa raha hai? Cadaveric spasm occurs in specific group of muscle. Incorrect पूछा है. Echo is there? Yes. Let me check the mic. Now it is okay. Now it is okay. Yes, friends. Image is also blurred. Image is also blurred. Another speaker is on. Okay. Image is also blurred. Okay. So, my dear friend, incorrect about the postmortem finding. Okay, no problem. We'll solve it out. Don't worry. Image is okay. Now, cadaveric spasm occurs in specific group of muscle. Yes, absolutely right. It occurs in the specific group of muscle. The most common muscles are muscles of hand. That's right. Postmortem staining common in lower limbs in drowning case. Actually, the option was this. This question was asked about the drowning. So, incorrect statement about the postmortem finding of drowning. The postmortem staining common in lower limbs in drowning case. Postmortem staining is common in lower limb in hanging case. In hanging. Everyone knows if the person is hanging, the body is hanging, the postmortem staining will be on dependent part. Yes, postmortem staining will be on dependent part. This is glove and stocking pattern. So, doctor, one thing is clear. This statement is true. Cadaveric spasm occurs in the specific group of muscle. Postmortem staining in drowning is in lower limb. No, my dear friend. What is the site of the postmortem staining in the drowning? Anyone can tell me what is the site of postmortem staining in the drowning? Anyone? Give me the answer. This will be on the face. This will be on the neck. This will be on the chest. So these are the site of postmortem staining in the drowning. So one thing is clear. This is false. This is false. Adipose hair occurs after the body comes out of the water. Yes, my dear friend. Drowning, the adipose hair. Anyone can tell me which climate is there for drowning? Which climate? It's very simple. It's a hot and humid climate. So drowning is seen in warm and humid climate. So adipose hair can be seen after the body has taken out from the water in drowning case. Okay. So this is again a true. Only B option is false. Greenish discoloration in subhepatic area is the early sign of putrefaction. I think you are thinking like drowning option was not given in option. Anyways, no problem. Cadaveric spasm is seen in specific group of muscle. It's a true option. Postmortem staining common in the lower limb. Here drowning was given. Yes, here drowning was given. Absolutely wrong option because I told you the postmortem staining is seen in face, neck, and chest. Adipose hair occurs after the body has taken out from the water. It is true statement. Yes, because it's a warm and humid climate. Now the last, greenish discoloration in the subhepatic area. Probably subhepatic area or right iliac fossa was given. It is a early sign of putrefaction. This is again a true statement. So anyways, my dear friend, yes, absolutely right. Which is the false statement? Which is the false statement? Postmortem staining in drowning is common in lower limbs. It can be seen in face, neck, and chest. It can be seen in face, neck, and chest. Abhi bhi echo aa raha hai? You are getting echo? Yes. Yes. So just remember this part. Here the option which is incorrect is option B. Okay. Anyways, so this is the next one. Okay. Now, the child is crying returning from the temple in a village. Still you are getting echo? Tell me, dear. Is it audible? The child in the temple, returning from the temple in a village with his grandmother, had burning sensation. Is it okay? Is it okay now? Okay. Burning sensation at the site of bite. At the site of bite. Now it's okay. Was taken to hospital. Now listen very, very carefully. The BP was 170 to 90 mmHg. Yes. So doctor, one thing is clear. BP is raised. BP is raised. Heart rate is increased. Priapism. What is priapism, anyone? What is priapism? It's a painful eruption of penis. And doctor, if you see, The BP is raised, it's a sympathetic stimulation. Heart rate is raised, that's the sympathetic. My dear friend, priapism is parasympathetic stimulation, and there is increased sweating and increased salivation. What is the next line of management? So you would say it's a bite of something. Chalo, ye batao, which kind of bite is this? Anyone can tell me? Which kind of bite is this? Anyone? Tell me, dear. Sympathetic stimulation and parasympathetic stimulation. Tell me, dear. Yes. Yes. It is scorpion bite. Now, a friend, the question is asked, what will be the next line of management? Now, next line of management is prazosin. And friends, this I discussed in this one-liner session as well as in image-based session. Yes, prazosin will be the best line of treatment. So here answer will be prazosin. You can see these are my notes. You can see these are the things which I have taught in the notes. There is an intense pain at the site of bite, swelling, blister, sweating, palpitation, chest pain, and one very, very important word, that's the priapism. Priapism. So these are the notes you can see. And my dear friend, it is due to release of catecholamines and the release which stimulates sympathetic and parasympathetic system. Very, very important. So, sir, here answer will be prazosin. Is it clear, sir? Now, the next question. The drunk alcoholic male with its alcoholic smell, with congested conjunctiva. So, sir, you can see the alcoholic smell with congested conjunctiva. Yes, if you are thinking about the snake bite, then it would be anti-snake venom. Congested conjunctiva is because of dilated pupil. Or you can say dilation of this, there will be congested conjunctiva. And normal motor function, walking stably. The person is having normal motor function, walking stably. Which of the following is correct? You can see the alcoholic smell is there. Everyone knows which kind of smell alcohol has, that is fruity smell. Which kind of smell the alcohol has, that is a fruity smell. And the motor function is normal. That means the person is drunk but not under the influence of alcohol. The person is drunk but not under the influence of alcohol. That's option A is correct. Alcoholic smell is there, motor function are normal. It means the person is drunk but not under the influence of alcohol. Very, very important one. बहुत simple question था, थोड़ा सा tricky था. In which firearm range only abrasion collar are seen? In which firearm range only abrasion collar are seen? Now, anyone give me the idea. What is the mechanism? Yes, very tricky. Yes. Would have been congested. Absolutely right. In firearm range, only abrasion collar. Now, everyone knows there are three effects. The smoke effect in firearm, this produces blackening. The smoke effect in firearm, this produces blackening. The flame and fire, it produces burning or singeing of hair. And gunpowder, which is unburnt gunpowder, it produces tattooing. Now, sir, very, very simple. Here they have only mentioned only and only abrasion collar. Now see, if you see this, I taught you in the regular classes. My dear friend, muzzle impression is seen in contact shot. So here, no muzzle impression has been mentioned. One very important word. No muzzle impression has been mentioned. Now, no blackening, no tattooing, no singeing has been mentioned. No blackening, no tattooing, no singeing has been mentioned. Only what they have mentioned, anyone? It's very simple. Only they have mentioned abrasion collar. Only abrasion collar. In close shot, what we have? Blackening, burning, and tattooing. In near shot, what we have? Anyone? It's a blackening, and tattooing or sometime tattooing. In contact shot, what we have, everything goes inside the tract. But as I told you, in contact shot, you will have muscle impression. So without any doubt, only abrasion collar, the answer will be distant shot. It will be distant shot. And you can see this was explained in the class in a very, very simple manner. It was too easy, yes. Because in contact shot, we have muscle impression. In contact shot, we have muscle impression. So just see, abrasion collar is seen in every condition. But if you see the difference here, in close shot, we have blackening, burning, and tattooing. In near shot, we have tattooing or along with this. And in contact shot, everything goes inside the tract. But only abrasion collar, the answer will be distant shot. Yes, my dear friend. Easy था question. तभी तो मैं बोल रहा हूँ forensic question was like little bit easy. Hallucination of insects crawling over the skin. That is a very, very lollipop question. Yes, my dear friend. Yes, it is known as tactile hallucination. And tactile hallucination in cocaine is also known as Magnan symptom. It was Magnan symptom. It is also known as formication. It is also known as formication. Tactile hallucination, formication, or Magnan symptom. Lollipop question. Very, very easy. So this I discussed in the class. This is the class. Actually, most of the questions are from class notes. We have seen the Magnan symptom, formication, that is seen in chronic cocaine abuse. Chronic cocaine abuse. Now, sir, this was an interesting question. I want your help. Now, tell me the exact question. A 16-year-old alleged rape victim, Lulu question, yes, Lulu question. The last 2 days, with mother brought to the doctor, what will be the first step? My dear friend, the options given were, number 1, take detailed history. Number 2, consent from mother for genital examination. Everyone knows any girl about 12 years of age can give consent for physical examination. Now, preservation of clothes. No, this is a part of examination. Yes, my dear friend. And start examination and documentation of injury. So it means that, see, this preservation of clothes is a part of examination. Yes, not to be done before consent. Start examination and documentation of injury, not to be done. This not to be done, not to be done. Now, my dear friend, before starting anything, you should get detailed proper history. So my question, because it's a common sense question. First we'll take the, yes, she's a minor, but she can give the consent for physical examination. After what age? 12 years of age. Yes, adipose tear can be seen in the drowning when the body is in water, because in water the climate is warm and humid. Yes, my dear friend, that can be seen. That can be seen. So here the answer will be, the first step will be the take detailed history. Take detailed history. That is the first step. Is it clear, my dear friend? Very, very potential MCQ. Okay. After this, you can go for examination after taking consent from female. Yes. Which is not a part of right strategy which is used for snake bite. Because I discussed in the regular classes, what is right? R for reassure the patient. I for immobilization in the snake bite. G for get to the hospital, go to the hospital. T, tell the symptom and history to the doctor. It means one thing which is not a part of right strategy, that is incision. So incision is not a part. R, reassure. I, immobilize. G, H, go to hospital. T, tell the history or symptom of the patient. This is Anishur Rahman, adipose tear वाला exactly क्या था? But adipose tear, if the body is taken out, that can be seen. We can see the adipose tear. If the body is inside, we can see the adipose tear. Yes, incision is the right answer. It's not a part of right. It is used for the snake bite management. Now we have seen this. Now this is very interesting one. Sir, actually, what was the image given? Anyone? What was the image given? It was a red blister. Yes, and the few people are telling it was surrounded by blackish area. It is surrounded by blackish area. Yes. Easy the question here. Definitely forensic was easier side according to me. Lulu question. Acha, take consent for genital examination. Take consent for genital examination. In this is also if we are taking consent for genital examination from the victim. But first we have to take the detailed history. Then you can take the consent for genital examination from victim also. Okay. So again, the question answer will remain same. Take detailed history. Now, anyone. Okay, in Temple case, the child is presented in emergency with 3 hours. He's telling that is also a correction that you can add, but the answer will be scorpion bite. The answer will be prazosin. Yes, this was a red blister surrounded by blackish area. Now, my dear friend, it is not a case of pemphigus. Everyone knows in pemphigus. Anyone? We all know that in pemphigus we can see the multiple erosion and involvement of mucosa. That can involve the buccal mucosa. Okay. Barbiturate poisoning. Barbiturate produces blister, and everyone knows these blisters are produced in friction area because of the one finding which is known as automatism. Friction area like interdigital cleft, inner side of the thigh, axilla, the inner part of this area that is seen in friction area. Now, what is left? Chemical burn. Yes, it was surrounded by blackish area. I didn't get the same image. It was surrounded by blackish area. Now, sir, what are the 2 important options left if you see? The chemical burn and antemortem burn. Sir, in chemical burn, yes, in chemical burn, the red line is absent, the line of demarcation is absent, and vesicles are rare or absent, I would say. So, best answer will be antemortem burn blister because it is surrounded by red line, and it is having the blister and surrounded by black area. That could be a case of charring, or you can say by smoke. You can say by smoke. So here the best answer is antemortem burn blister. Antemortem burn blister. So my dear friend, these were anything like you want to correct, but I'm telling you all the options which I collected from different sources. Anyone? Yes. Your notes from other app can be used in synchronized to your prep lecture. Okay, no problem would be there. But what I'm telling you, see, again I'm revising all the question. Number 1, which is not a finding, which is antemortem, washerwoman hand and finger. That can be seen in antemortem as well as postpartum drowning. It's a non-specific finding. Okay, dear? Second question. What is the antidote of morphine? Lulu question. It's a naloxone. Yes, naloxone. Now, Blackfoot disease and peripheral. Yes, previous year question teaching was awesome. Thank you very much. But sir, again, I'm telling you, most of the question which I discussed in YouTube session, the last YouTube session, you got many questions out of these. Even every question, like directly and indirectly, came from these sessions. Yes, artery, Blackfoot disease, which is having the bitter substance in test, it's the alkaloid. Now, incorrect about the postmortem finding. Cadaveric spasm is seen in specific group of muscle. It's true. Postmortem staining in lower limb. In drowning, it is not seen. In lower limb, it is seen in the case of hanging. Hanging, that's asphyxial death, suicidal. This is a scorpion bite. The drug of choice was prazosin. Yes, FMT was easy. Absolutely right. FMT was easy. The person was drunk but not influenced by alcohol. Yes, my dear friend. Only abrasion color, it was distant short. Agar threatening, burning, tattooing kuch hota, so that would have been different option. This I discussed in the class. Tactile hallucination, formication, and again a Lulu question, lollipop question. Yeah, first take the detailed history, then you can go for consent for examination. Yes, absolutely right. Which is not a part of right in season. And this is an image of antemortem burn blister. So my dear friend, this is all about forensic medicine. There are 11 to 12 questions. All were easy to moderate level, I would say. Easy to moderate level, not like the tough level. 1 or 2 questions were tricky. There is a blister question, only image was given, that was tricky. And 1 question of the antemortem findings were little bit tricky. But anyways, sir, this is all about forensic medicine from Dr. Akhilesh Jhamad. And again, I'm telling you, forensic medicine questions are most of the time from notes only. Okay, dear friends? So, good luck. Goodbye.
Good evening, dear students. And continuing with the anatomy subject here, the recall session for your exam, which was conducted just very shortly. Anatomy recall session, INI CET, May 2023. I'm hopeful that the exam went well and you will be giving us good news as soon as possible. Somehow there is a glitch from my system. There was a glitch. We have somehow managed to cope up with that, but my activity will be a bit limited. So I'm hopeful that it will be eventually whatever the purpose of this session is, it will be fulfilled. And obviously then we'll get good questions, feedback from you. I'll get some more questions in the recall, and then we can have a better format of discussion as such. So, मत याद दिलाओ एनाटमी सर। भाई कभी कभी ऐसा होता है कि तैयारी हम करते हैं, एग्जाम होता है, एग्जाम में कुछ याद आता है, कुछ नहीं आता है। But again, I believe that it is a quest, and the quest is not fulfilled until we achieve our target. So let us start the session. And the very first question, what I believe is, like most of the questions, they were from the repeat topics, And the questions which you would have answered, you would have forgotten, because we remember those questions which were difficult and we could not answer. So I understand this question, everybody would have answered correctly. What do you think? SRY gene is present on. Yes, Y chromosome, short arm, that is correct. It is the SRY gene, sex-related gene, which is on the Y chromosome, short arm. If you remember, this is, let me take a pen here, that will be better. So as you see, this is an acrocentric Y chromosome, and on the acrocentric Y chromosome, there is a short arm which we are focusing upon, and on that, there is a region which is the region Y, SRY gene, and this gene will code for a protein which is testis determining protein, and then the individual will turn into male. So I understand that most of you, almost everybody would have answered it correctly. This was your question. SRY gene is present on. If it was a bit different, you can mention, but it is Y chromosome, short arm. So I am hopeful that all of you must have answered it correctly. And because these are simple questions, I know that most of you would have forgotten whether this question was there in the exam or not. Only the questions which you cannot answer are remembered, in fact. Okay, let us move on to the next question. This is again one anatomy question, but it can be discussed by ENT faculty as well. Arrange the neural columns in medial to lateral order. Now we continually discuss neural columns, and the examiner continually keep getting some questions which we find difficult because the topic itself is difficult. But anyhow, if you remember, we sometime like during our practice session or revision sessions also we do it. SVA, then there is SVE, and then they have given the GSE. I just want to confirm whether these were the options or some different options were there, GVA. So in the chat, you can mention whether these were the options given to you or maybe some different options could be there. See, what happens is during development, the neural tube is going to divide into two parts. There is one anterior basal plate, and then there is a posterior alar plate. When you say anterior basal plate, it will be giving us motor pathways, that is the efferent E pathways. And if you are talking about posterior alar plate, all were afferent. Okay, so all of them were afferent, right? Okay, so we know there are 4 afferents, and then things become a bit easy. But then let me discuss it entirely. So the anterior basal plate in the neural tube will give us motor pathways, the efferent pathways, and posterior alar plate in the neural tube will be giving us the sensory pathways, which are also called as the afferent pathways. Now, as you are suggesting, Amruta is telling all were afferent. There are 4 afferents, and they would have given the 4 options, as I understand. Efferents are 3, so we are not going to focus much upon efferent, but then you should know that they are counterparts. If you have 3 efferents, then you will have 3 afferents also. There is only one additional afferent which is missing in the efferent. Total 7 neural columns are there. As you can see, 4 afferent and 3 sensory. Sir, all were afferent pathways that were given. Okay, I can understand. So as I'm suggesting, see, this is the neural tube which is developing, and there will be 2 plates. There is a posterior alar plate, and then there is anterior basal plate. Anterior basal plate will be giving us motor pathways, 3 of the efferent, which we are not concerned with at the moment. And posterior plate is giving afferent pathways, 4 of them. And those 4 were given to you in the question. But to understand those afferent, you should start with the efferent. And these are the 7 columns which we are talking about. A bit difficult topic and requires a lot of revision. But let me simplify it. What happens is, I can go back to my diagram, which I have used earlier. See, there will be one GSE neural column, journal somatic efferent, which will be taking care of most of the skeletal muscles. Then there will be one GVE, general visceral efferent, and they'll be taking care of pharyngeal arch muscles. So skeletal muscles are two types basically. Most of the skeletal muscles, they are general somatic efferent, and there are some skeletal muscles which are pharyngeal arch muscles. They will be general visceral efferent. And then there are cardiac muscle, smooth muscle, which is the I'm sorry, I have written here GV, general visceral efferent. If it is general visceral efferent, there will be the cardiac muscle and smooth muscles, basically autonomic nervous system. So cardiac muscles and smooth muscles will be GVE. If you're talking about pharyngeal arch muscles, then they will be SVE, special visceral efferent. So special visceral efferent are the pharyngeal arch muscles. I'll repeat again. See, most of the skeletal muscles are GSC, general somatic efferent. Some of the skeletal muscles are pharyngeal arch muscles, which are special visceral efferent, SVE. And then there are cardiac and smooth muscles, which are general visceral efferent. Three motor, you'll have three sensory column also. For GSC, you will have GSA, general somatic sensation. For GVE, you will have GVA, general visceral efferent sensation, means the visceral sensation. And for SVA, you will have SVA, special visceral efferent. So as you have E, counterpart will be A, general somatic efferent, general visceral efferent, special visceral efferent, but there is one additional efferent, which is SSA, that is special somatic efferent. I'm not going into much of these details, but if you wish to see the sequence in which they are arranged, it is shown here. You can see that the very first one here is GSE. And then I think what we'll do is, when I'll make a video, because I'm not very comfortable with the teaching this way, what I do is normally I'll have a TV in front of me and I'll be drawing, and that way it becomes better. But if you are asking for the arrangement, if there's a GSC, you see here, there will be a GSA also. This is GSA. So there'll be a particular arrangement, and that arrangement, when we make a video, I'll discuss it perfectly there. It is not possible for me to discuss it here because there is a limitation of using these tools, which I'm using at the moment. But if you want the answer, say if this is the question, SVA, SVE, GSA, I think it will become A. I think we'll discuss it in the video. That will be better. Let me just leave it here, or I can write it in the chat later. Now, as it comes to the next question, I think this is a repeat question, and you want the auditory pathway to be discussed, and that is from peripheral towards the central. So again, I believe most of you must have answered it correctly, because it is a repeat question and has repeated itself quite frequently. You use the mnemonic, which is SC, then you have slim, and 41, 42. So what is SC? It is the spiral ganglion, which is the auditory ganglion, basically in the inner ear. And then you will have the cochlear nuclei at the pontomedullary junction. Then you have the superior olivary nucleus, the lateral lemniscus, inferior colliculus, medial geniculate body. Let me show that in a diagram as well. And superior temporal gyrus, Brodmann number 41, 42. So as you see, we are starting with the inner ear, the organ of Corti. From there, it will be coming to the spiral ganglion. That is because cochlea is spiral. So in that spiral, there'll be a spiral ganglion, which will be receiving the auditory information. And then you have to reach the cochlear nuclei, which is at the pontomedullary junction. And after that, you have the mnemonic SLIM, slim, and then 41, 42. Now, when you do that, S is superior olivary nucleus, which you can see here, because most of the auditory pathway will be crossing in the trapezoid body. So superior olivary nucleus, after that, L is the lateral lemniscus, then I is the inferior colliculus, which is in the midbrain, lower midbrain, and then M is the medial geniculate body, which is metathalamus, and then 41, 42 is the superior temporal gyrus, which is also called as Heschel's gyrus. So I'm not telling you anything new here, and it is a repeat question, just the mnemonic you should remember, and you can expand that as the question's details are asking. And in this particular question, if we want to look for the mnemonic SC and slim 4142. So S, you will have the spiral ganglion. These two are in focus now. But after that, C, cochlear nuclei. So this is fitting well. And after that, you have to start slim 4142. So S, superior livery, L, lateral lemniscus, I, inferior colliculus. The answer to this particular question will be choice number B. Okay, then as we move on, you can see, let me know, was this the question they were asking? A muscle shown and which is attaching to medial border of the scapula and appears to be rhomboid major. So what's the question on rhomboid major? Kindly let me know in the chat. And if it is rhomboid major, then it is understood that it will be actually attaching to 2 points, the origin and insertion. Origin is the vertebral bones and insertion is the scapular bone. And whenever the muscle is contracting, yes, it was labeled as rhomboid major and minor. Okay, so both of them work almost the same way. And as you see, the origin is vertebra, insertion is medial border of the scapula. So when the muscle is contracting, it will shorten. And as you can see, it will be a vector which is going like this. And you can break this vector into X direction and Y direction. So it is pulling the scapula towards the midline, which is called as retraction of scapula. And it is also pulling the scapula upwards, which is elevation of the scapula. But then you have to tell me the choices, multiple correct type. Okay, that is what I was wondering, because these choices, they appear to be more than one answer here. So it elevates the scapula. I can agree with that, though it is basically done by trapezius and levator scapulae. But trapezius and levator scapulae can be helped by even the rhomboid muscles, because as you know, this is the vector. See, the fibers, the direction of the fiber will tell us about the activity of the muscle. So it can elevate the scapula. Yes, of course, A is good here. And it can bring the medial border of scapula to the midline. So it is also a retractor. So not only it is elevated, it is a retractor. And then as you see here, to answer this C and D means to choose between them, you look at this diagram. See what happens when we are doing shoulder abduction. We have to rotate the glenoid cavity of scapula upwards for abduction. But when you bring the arm back, which is adduction, it'll come back. Now, to elevate the glenoid cavity superior, as you see here, this is the glenoid cavity, and it has to be elevated superior for shoulder abduction. There are two muscles, basically, that is helping in lateral rotation of the scapula, elevating the glenoid cavity superior, and they are the trapezius and serratus. Now, if you have taken the arm away, you have to bring it back. This is ADD now, which is adduction. So which muscles will be working to bring it back? Or which muscles will be bringing the glenoid cavity back or inferior? And they are the antagonistic muscles. So for abduction, we do the lateral rotation of scapula, raising the glenoid cavity upwards, and opposite is ADD adduction, where you have to bring the glenoid cavity inferior. So the antagonistic muscles will be levator scapulae and the rhomboid muscles. You can understand these muscles are antagonistically working for trapezius and serratus. If trapezius and serratus were doing lateral rotation of scapula for shoulder abduction, they will be helping in shoulder adduction. How? By taking the glenoid cavity downward. So I hope you got the point. Maybe only two options are correct. Are you sure? Subscapularis retract. Subscapularis muscle is basically ADD, adductor as such. So, but you can notice that this is medial rotation of scapula. And in this medial rotation of scapula, there is turning the glenoid cavity downward. So according to me, even this is your answer. Rotate the scapula, which is medial rotation, and then tilt the glenoid cavity inferior. So there should be 3 answers, because choice D is basically a function of trapezius and the serratus anterior, what you call as overhead abduction. So what do you think? A, B, A and B, A and C, B and C. Okay, it was like that. Okay, but in option, there were only 2 answers. You can give only 2 answers. So have I got the choices correctly mentioned here, or is there any change in these options? I understand that there can be only a pair of answer. Either it is A and B or B and C, something like that. So you can give only 2 answers. But here I have got 3 answers. So were the options in the similar fashion, or there was some difference? Okay, but anyhow, as the topic goes, I hope you understood that if these were the options were confusing. Okay, so let me work upon that, because of course it takes a lot of time. I'll be watching other session of YouTube videos. Some students, they do upload some of the sessions. And but finally, what we understand is this muscle, that is rhomboid major minor, can elevate the scapula, retract the scapula, and rotate the scapula medially, medial rotation of scapula, so that glenoid cavity faces inferior and antagonizing the muscles of overhead abduction. Yes, if depressed the glenoid cavity was there, was it depress or take it inferior? Because the terms are important here. So I'll be working upon these questions and uploading the video with more details. At this moment, let us move on to the next question. What do you think? This was the question which is appearing like a repeat question? Option B was depression, not retraction. Okay, so just give me some time. I'll collect the correct options and make the final discussion video. At this moment, look at this question. Was it the similar fashion question? Patient presenting with abnormal sensation in the little finger, part of the ring finger, weakness of the medial palm muscle. What is that? Maybe some hypothenar muscles they are asking about. Most probable site of injury. Was it like this? Why don't our faculty appear for exam secretly? See, man, a 50-year-old person cannot be appearing for exam secretly. They'll immediately spot me. That will be the best thing if the faculty could appear in the exam and medial palm muscles was okay. So if this is the way the question has come, then I think you all know the answer. This is talking about the, if it is this sensation and these muscles, the hypothenar muscle, we are talking about the ulnar nerve. And if we are talking about ulnar nerve, then we understand ulnar nerve is related with this point number D, running behind medial epicondyle. So that would be our answer. And if it is lateral epicondyle, it will be the radial nerve. Radial nerve can also be damaged and mid-shaft humerus fracture. And if it is this marker A, that will be basically the axillary nerve. Let me show you the diagram here. But as such, if it is ulnar nerve, the answer should be choice number D. Ulnar nerve injury behind the medial epicondyle. So as you see, we are at this moment looking at the right upper limb and the right humerus basically, and a nerve which goes around the surgical neck of humerus is axillary nerve. So if a fracture at the surgical neck, the axillary nerve will be damaged. If it is fracture mid-shaft humerus, could be injury of radial nerve. And if it is fracture medial epicondyle, ulnar nerve passing behind medial epicondyle could be compromised. Or if it is something to do with the lateral epicondyle, right in front of that is again the radial nerve bifurcating, means giving 2 branches, the deeper and superficial branches. So here also there is a chance of damage of radial nerve. But our question was more specific for ulnar nerve. So we'll go for medial epicondyle. That means in this particular question, your answer should be here, marker D, and choice number D. Okay. Somehow I'm not very comfortable with this kind of teaching. Actually, sitting posture is not the way I teach, and not using pens, using mouse to write down on the screen. Actually, somehow this transmission from my TV did not work today. So anyway, I'll be making a better format video very shortly. Okay, what about this question? Was this the question in front of you? As you see, anterior relations of the third part of duodenum are all except. So kindly mention in the chat. No, I don't want to relax when I'm teaching. That can be the worst thing happening to a teacher. A teacher cannot relax when he is teaching, and obviously sitting posture is a relaxing posture. You would have seen me. I never teach sitting. Today I have been forced to do that. What to do? Okay. Body and fundus was the option. Okay. So you mean to say a gallbladder, not only fundus, it was body also. Okay, fine. That actually doesn't change much of the our logical conclusion of answer. And what about the other options, like superior mesenteric artery was there, root of mesentery was there, and jejunum was there? I believe so. And again, somehow anatomy is very vast, and examiner has a wide ground to play around, and this is one of the way. But as such, if you keep watching videos properly, somehow you can come to a logical conclusion. Not sure of jejunum. And let me show you the diagrams. See, L1, 2, 3 vertebra, that is the vertebra where we have the jejunum. Jejunum has 4 parts, part 1, part 2, part 3, part 4, and C-shape loop, as you see, this second part where you have the head of pancreas related. So it is the second part of the duodenum which relates with the head of pancreas, but then it relates with the first part superiorly and third part inferiorly as well. I mark the root of mesentery. Okay, so let me show you the details now. You have these details in BD Charasya, in your Inderbir Singh, and of course in our videos, but I don't want to, continuously telling I have taught you, I have taught you, I have taught you. That doesn't make sense. If you have answered, then it makes sense. So let us just go through it. As you see, the superior mesenteric vein and superior mesenteric artery, they will be entering the root of mesentery so that they can supply the small intestine, because superior mesenteric vessels are the vessels of the midgut, and they have to supply some part of the small intestine. To supply that, they must be entering into root of mesentery, and from there they can supply the small intestinal midgut portion. That is why they are, all the three are in front of the third part of the duodenum. So as you see, it is not only superior mesenteric artery, but also the vein entering the root of mesentery, and they'll be all running in front of the third part of the duodenum third part, anteriorly basically. Plus, you can see jejunal loops are there, and jejunal loops are not only anterior to the third part, but they are inferior also. So anterior and inferior relation with jejunum. Now, by this time, you would have understood that the exception would be the gallbladder. As you are suggesting, it was not only the fundus of gallbladder, but it was also the body of gallbladder. So if you are talking about the gallbladder, as such, it is relating to the second part, duodenum second part, not the third part, because it is not so much coming inferior, reaching the third part. See, this will be the third part. So that gives us the hint that if we are talking about anterior relation of the duodenum, and if we are talking about the gallbladder, may it be the fundus or the body. It will be relating to second part of the duodenum, which you can see here. Duodenum is a C-shaped structure having 4 parts, and it is relating to second part, not the third part. And in the video discussion, definitely we'll be having a better orientation. But as such, you can come back to this question. Anterior relation of the third part of the duodenum are all except, and obviously we have just seen superior mesenteric artery plus vein is there, entering root of mesentery and some loops of jejunum, but not the fundus or body of gallbladder because they relate to second part. Relations are important for a surgeon, of course. So that way this question becomes important. Now, as we move on to this next question, just let me know, I'm sure that it was some matching kind of question, and they were asking you the position of the appendix, and some image was given, and they would have marked something like A, and then B, and then C, and D, and they will be asking you some pairing. So just let me know, was it something like this, like retrocecal, preilial, postileal, subcecal, pelvic? That kind of options were there? Paracecal, no preilial. Okay, paracecal. See, if you look at your standard textbooks, like for your first MBBS, normally you are using B.D. Chaurasia and Vishram Singh, which are quite authentic. And as you know, mostly if we search for appendix, it will be retrocolic, retro means behind, so behind the colon, and 65%, almost 65% of the individuals, they'll be having retrocolic appendix, which is shown here. And the second commonest, you can say the pelvic region, which is, let me find out where it is, here, pelvic 4 o'clock position, and about 30%. That is the second commonest, and then there is multiple variety, means different individuals can have different locations. So if you are talking about the terminal ileum opening into the cecum, there could be a pre-ileal, means anterior to ileum, post-ileal, which is posterior to ileum, but you are talking about paracolic, I believe. So this is paracolic here, 2%, and it is given this way. So this is paracolic. Image was quite clear and easy to guess the things. Okay, fine. Teacher showed same image in the recall session. Okay, fantastic. Then I believe there is no confusion here, and it is just a matching type of a question. So we'll have to just find out A is this particular, means option A, B, C, D, we can find that way. But this is the diagram which will help us. Okay. Right. Now, just let me know, was this the question? Because it will be a repeat question then. Muscle supplied by superior gluteal nerve, and then they are giving us certain options and some, option A, B, C, D in a combination. So just let me know if this is the format of a question, it is a repeat question. Or was the format different? I marked root of mesentery as it is posteriorly attached. Yes, root of mesentery is posteriorly attached. I agree with that. This is what you are talking about. But then this root of mesentery, see, the duodenum itself is retroperitoneal. And because duodenum is retroperitoneal, it is also attached to posterior abdominal wall. And mesentery is running anterior to the duodenum. I agree with you that root of mesentery is posteriorly attached, but even the duodenum itself is posteriorly attached because it's a retroperitoneal structure. So root of mesentery comes anterior. These vessels come anterior to the third part. Okay, let me come back to this question here. Maximus was not there. Okay, Maximus was not there. Okay, fine. And then no gluteus maximus. Okay. If gluteus maximus was not there, then you should have answer 1, 2, 3, 4. Because see, though you may not be knowing, normally what we teach is superior gluteal nerve will supply 3 muscles. starting with gluteus medius, and then we'll say gluteus minimus, and then we'll be talking about tensor facial lata. This is classroom lecture. But I always advise the students to go through previous year question discussions also. And because it is a repeat question, and if you have been through those videos, I have mentioned it also supplies piriformis. Now, if I say it also supplies piriformis, where did I get that information? Of course, Gray's Anatomy. So according to me, my answer will be choice number A, 1, 2, 3, 4. Because not only superior gluteal nerve supply gluteus medius, gluteus minimus, tensor facial lata, but also giving branch to piriformis. What do you think? Accept was the question? Was there accept in the question? If accept was there in the question, then the question then means that is not a question at all. Accept was the question. No accept was there. I don't think accept should be there. So as such, I believe it is a repeat question, and already we have discussed, you will find the discussion on YouTube, and 3 combo over there, okay? None of the 4 combo, okay? See, if that is the situation, as we are discussing, most of the books, they will not mention piriformis. Most of the books, they'll not mention piriformis. So you can just go with gluteus medius, minimus, and tensor facial lata. But Gray's Anatomy does include piriformis in superior gluteal nerve supply. So a word of advice, first answers will be gluteus medius, minimus, tensor facial lata, no issue. But if you have to add, then you may add piriformis. Or if you have to remove, then you can remove piriformis. Because I really doubt that B.D. Chaurasia or Vishram Singh are adding piriformis there. Okay. So if you had only a combination of 3 choices, then it's quite. But okay, here I'll tell you one thing. Examiners are very smart. They have somehow made you think that superior gluteal nerve is not supplying piriformis. And next time when the question will come, they'll add piriformis. So these are, the examiners, they use such tricks. But here, I think you have got ample information that additionally, it does supply piriformis. If you have to exclude, you may exclude piriformis, because normally most of the authors, they do not include piriformis. Okay, so these are the, let me change the color of pen because it will not be evident here. So you see, this is greater sciatic notch, superiorly passing superior gluteal nerve, supplying these muscles, gluteus medius, gluteus minimus, tensor facial lata, but also piriformis, according to Gray's Anatomy. Not going into much detail here. We'll do that when we make the proper video. Okay. So these are the questions which I have got. Kindly mention any additional question which you remember, and I don't have them because it was a very short duration. I could not collect most of the questions. I am only 25% prepared at the moment, but somehow I was advised that you should do a session. So I started it halfway in my research. Kindly add any questions which the examiner has asked and I have missed. That is my homework basically, but if you could help me. Not very satisfied with this session myself. Okay, so let us just go through the questions once again. It was anatomy recall session, and INI CET May 2023. SRY gene, short arm, Y chromosome, coding for the testis determining protein, the male individual. Then this is the location. Then you had this arranging the neural columns, cannot be discussed properly here in this format. Better make a proper video for that. And then this is the auditory pathway. As you know, SC slim 4142 is your mnemonic. Choice B should be our answer. Then this is a pathway we have discussed. This muscle, if they were asking, must be rhomboid major minor, and they are, this is the pull. So X direction is retraction, Y direction is elevation, but they also take the glenoid cavity inferior. So according to me, ABC should be the answer here. Then, as you see, this is a repeat question. If they are asking for ulnar nerve, then medial epicondyle. Option D, marker D. Sorry, what is this? Sir, there are two questions regarding SRY gene. Yeah, I think SRY gene, they have asked, the other question would be testis agenesis, I believe. If you do not have Y chromosome short arm, see, you may have Y chromosome, but if there is no SRY gene, then there'll be no testis. So testis agenesis, was that a question? Some students have told me. So I think that was, sir, there are two questions. Dr. Anupam, you are mentioning there are two questions. Yes, I understand. So what was the other question? Well, okay. Diksha, what was the other question? Can you please provide me with the options at least? On SRY gene, what was the other question? This, and there was about SRY gene deletion. Yes, deletion, yes. If you have deletion, there'll be testis agenesis. Testis will not form. So was that an option? Okay, let me take you to the question itself. Just a second. If I have that question, no, I don't have. So if you could help me here. No, testis was not in the option. Okay, I'll find out myself. That is my job, my homework. The video which I'll be making, I'll point mutation. Okay, so it'll be something related with the genetics, I believe. Though this kind of point mutation and removing the SRY gene is very rare. Deletion, insertion. Okay, so it is about genetics. I got it. Right. Mutation, translocation. Yes. I believe genetics will be taken care of by biochemistry faculty or pathology faculty. Normally, I don't encroach upon genetics, but maybe in the video discussion, I can mention it briefly. Regarding location and other is most common mutation. I got it. I got it. Now, as we are revising, you can see there was this question, anti-relation of the, third part of duodenum and the exception. So we have seen the fundus and body is related to second part. And then we have got this question, which is on the positions of the vermiform appendix. And we have one question was regarding Müllerian. Yes, Müllerian and Wolffian duct. Okay. Can you give me some more details about this Müllerian and Wolffian and Müllerian duct? What was the question on Wolffian and Müllerian duct? Somehow it begins in the embryology and moves on to OBG and pediatrics, because these subjects, they take care of these Wolffian and Müllerian duct anomalies. Okay, that is my job. I'll find out all the details, all the questions, no worries. I don't want you people to stress so much. Most common anomaly, insertion, deletion, inversion, point mutation. We'll have to work upon that. And then this question. So if it is just a combination of three things, no problem. You can have gluteus medius, minimus, tensor facial lata. If you have to include or exclude, you can do that with piriformis. Option was seminal vesicle. Okay, so you are telling about the derivatives of Müllerian or Wolffian duct, I believe. That would have been one of the question, I believe. So if it is Wolfian, Wolf is normally rated to male, and the Müllerian is for female. So if it is Müllerian duct will be giving you the uterus, the uterine tube, upper 1/3 of vagina, and Wolfian duct. Wolf is representing the male. So if it is Wolfian duct, then you can start with the, say, common ejaculatory duct. You can go to ductus deferens, the vas deferens, and even the epididymis. So epididymis, the ductus deferens, vas deferens, which is the other name, and seminal vesicle, and the common ejaculatory duct, they'll all come from the Wolfian duct. Okay, so 4 derivatives of Wolfian duct basically, which is carrying the semen, basically sperms, the epididymis, the ductus deferens, the seminal vesicle will add on to semen, and then common ejaculatory duct. Wolf for male. Okay, so I think I should stop here, not be taking much of your time, and God bless. We are very much waiting for the results and the happy news you are going to convey to us. And it will, why no fructose is in semen was asked. Okay, why you don't have fructose in semen? That is a question. Congenital absence of vas deferens, ejaculatory duct obstruction, both or none. Congenital absence of vas deferens and ejaculatory duct. If it is congenital absence of vas deferens and ejaculatory duct, must be with something to do with the Wolfian duct. Totipotent weeks. At 8 weeks. See, for a testis, it is by 7th week. If it is ovary, it is 8 to 10 weeks. So what was the question? Totipotent is before 8 weeks, actually. You can say 6 week. Indeterminate embryo, it is 6 week. By 7th week, it will have decided to become a male. And by 8 to 10 weeks, it will go in female format. There are 2 different questions. I understand. I think I'll just have to do some homework. We'll find out the questions, appropriate options. So don't worry at this moment, because obviously it is difficult for you also to recall the options appropriately. We have several sources. So finally, we definitely get the options with us. Okay, right. So the next session will be taken by Dr. Ankit, and that will be psychiatry. Let me just see if he has arrived.
So very good evening everyone. Thank you sir for an amazing session of anatomy. So very good evening everyone. How are you doing everyone? How are you all? Hope I am audible and visible. Please let me know in the chat box. Hello Amruta. Hello everyone. So we'll be discussing the psychiatry questions. So we'll be talking about, or we'll be doing the post-mortem, or I can say we'll be recalling the questions of psychiatry in yesterday's exam. So good evening Diksha. How was the psychiatry paper? How were the questions? So we'll come to the questions. We'll try to collect these questions. So good evening Diksha. Good evening Urvashi. Yes. So first of all, again, this session is, to get all the questions, and actual questions and explanation will be putting up in the Prepladder app. Good evening, Dr. Anupam. Good evening. So, let's try to analyze the paper. Let's try to have an analysis. Now, this analysis, what I'm doing is also will be beneficial for the examinees who will be giving the exam in future, maybe, NEET, PG or next, whatever is coming, and even for the FMG examinees in the future. Good evening. It was moderate, yeah. I would also, vouch for that. I would also feel that it was moderate. So, when we have analyzed the paper and the questions which we have got, and of course, I'll try to get more questions if they were there. So, I could collect around 12 questions of psychiatry. And, when we bifurcate them topic wise, if you see that bifurcation again is in the previous lines only. Psychopharmacology, if you see, there were 5 questions, and thankfully one new question which we were discussing in both our last session of INI CET exam actually came. So, very thankful, that came, and I am sure that must have been helpful to all of you. Symptom wise, when we see, there were 3 questions. Again, this topic of dementia or organic mental disorders, I have been discussing this topic again and again. It's a small topic, but again it is very important. Again, you can see, one question came, again a simple question was there. Good evening, Dr. Mohammed. Good evening. So, let us see, let us wait. Let us first start the discussion. Substance use, again, substance use, 2 questions were there, and 1 criteria question was there. So, overall, if you see the topics, again, these were some of the topics from various, segments which we are, discussing. And again, their, old love affair with lithium and alcohol continues. Again, we have been discussing, this is a very, repeated topic which have been occurring years and years. So, this, this long-term love affair is continuing of the examiner. Okay, good evening. Right. So, let us try to take the questions. And before that, again, if I ask you, what was the severity level, how was the paper? So, what would be your, so I am talking about in terms of psychiatric questions. So, what do you think was the, was the severity on the severity meter? What was the paper about? Was it easy? Was it moderate? Was it difficult? Seeing the questions, I would say that yes, it was moderate. It was not very easy. Some of the questions were tricky. So, let's try to take up the question. So, again, I would like to tell you that, out of these 12 questions which have come from psychiatry, yes, Urvashi, great. Yes, out of the 12 questions, again, 11 questions came, directly from the Prepladder app lectures which we have been doing. So, I will be, taking up those segments from where the questions have come, and also from the revision video. So, the revision video, 1 month back and 2 days before the exam which we did, a lot of questions came from that. So, overall, we could say that around 11 questions came from the topics and from the, all the lectures we have been discussing. So, let us start with the first question. Yes, Roshan, yes, I would say yes. Some questions were tricky, some were direct. Again, this is a new question, but I am sure this should not have been new to all of you, because we have discussed this new drug. I have emphasized, in last 2, sessions which we have met on this drug for Rett syndrome. What was the answer? Hello, Maya, what is the answer? So, I hope all of you were able to mark correctly. Were you able to mark this answer correctly? So, we have been discussing this again, thankfully this question came, and very good. So, what is the right answer? Yes, it is trofinetide. We have been discussing this question, it is trofinetide. So, again, we have discussed this in the video. Trofinetide is a drug which has been recently approved by the FDA for Rett syndrome. So, this is from the discussion we had 1 month back before the exam. This is the new drug, it is a tripeptide. I also told you some important things about the drug. Again, for future examinees, these things may also be asked. Right now, again, we have discussed this, the name was very important. It's a tripeptide. It's a tripeptide of glycine, proline and glutamic acid. Very good, yes. So, you were able to mark it correctly. Yes, it is an analog of amino terminal tripeptide of IGF-1, insulin-like growth factor 1. It has anti-inflammatory property and it stimulates synaptic maturation. What about the other options? Can you see and can you tell me, were these the options? I have tried to accumulate the options so that again you should know we can compile an exact question. So, were these the options or were there any different options? Anybody? Can anybody tell me, were these the options? So, from the students, from various sources, we could collect these options for the exam. So, let us take up these options only. So, let again, You will be discussing these in pharmacology. So the drug Eurogepant, the Gepant group, again it is used for migraine. Apitanizumab, again it is used for migraine. These are basically CGRP, receptor drugs. Then lasmiditan, again this ditan drug, again these are drugs used for migraine. Very good. These are the drugs, yes. So options are correct option. So again you should know, if you knew these drugs, you could have read that yes, these drugs are used in migraine. And some students said that this was the drug which was mentioned, again a relatively new drug, sparsentan, again it's used for primary IgA nephropathy. So these were some of the options which I think in pharmacology we will be discussing more in detail. Our answer for this question is A. Is it clear to everyone? The answer is A. Right, correct. The options were correct. So this was, I think this is the best possible options we could get for the exam. Now let's move to the next question. Am I audible and visible? Let me know in the chat box. Am I visible? Is the video working? Let me just, yes, correct. Right, so let's come to the, yes it is, yes, okay. So let's come to the next question. So again this question, again we have discussed this question. If you see in the app, we have discussed this question. Even in the discussion sessions we have discussed all of the following are reversible cause of dementia, except if you see the PYQs, if you see the PYQ, one of the first INI CET exam which held, they asked a similar question, but it was related to which of the following is not a subcortical dementia. This time they have asked classification on reversible and irreversible. Okay, so look at the options. The first is normal pressure hydrocephalus, hypothyroidism, Lewy body dementia. Again, we have been discussing, emphasizing on Lewy body dementia a lot, and vitamin B12 deficiency. So out of this, they are asking which of the following is reversible cause, except you have to tell. So which of the following? All are reversible cause. So I think was except there. Oh, I think except was not there. Which of the following are reversible causes of dementia? This was the question. Reversible causes you have to tell. So if you've seen, okay, except was not there. Yes, except was not there. So again, as you can see in the video lectures, we have been discussing neurosurgical causes, and one of the neurosurgical causes is normal pressure hydrocephalus. If you do shunting, you treat it, the dementia is reversed. Also, we have been emphasizing some metabolic causes, especially if you see, even in the videos I have highlighted, vitamin B12, hypothyroidism. These are some important metabolic causes. Even in the 2 days before the exam, we have discussed this point when we were discussing reversible causes. There also we have discussed vitamin B12 deficiency, hypothyroidism. These are reversible causes. So what is the answer? So yes. So we know that normal pressure hydrocephalus, hypothyroidism and vitamin B12 deficiency, these are reversible causes. And of course, we have been discussing in detail Lewy body dementia. It is not a reversible cause. It is a irreversible cause. So the right answer to this question is option D. The right answer is option D. Is it clear to everyone? Again, this is very important topic. Organic mental disorder, dementia, delirium. These are very important topic, right? Now let's talk about the next question. La-Bella indifference, again a very simple question. What is the answer of this question? Very good. So what is the answer to this question? La-Bella indifference is seen in, again if you see, it's a topic PYQ. It's a PYQ, they had asked this question about conversion disorder in the November 2022, and now they had asked something related to it. Very good. So La-Bella indifference, again a easy question. It is seen in conversion disorder. Were the options same? Were these options right? So these were the options. So again we have discussed this again when we were discussing again the revision. Even in the video lectures we have discussed this. La-Bella indifference is seen in conversion disorder. So this question in fact they gave you. So that is why I always say they sometimes repeat the topic. So in the question they had asked that a young girl after death of her mother, she suddenly becomes blind but seems to be less bothered about this blindness. So this question in fact was given in the previous INI CET, and there I explained you that this symptom, this careless attitude of a serious symptom, the girl has turned blind but she seems to be careless about this symptom. She is sitting very calm. She is not bothering about that serious symptom. What is this phenomena? This is La-Bella indifference. Right, very good. Yes, it is La-Bella indifference. Is it clear to everyone? This is La-Bella indifference. Now let's talk about the next question again. As we are discussing, lithium is a very important topic again and again. So this is again, they have make a new question out of this lithium, but again let us try to see which of the following statement is true regarding lithium. So let us try to see what is the answer. Anybody? What is the answer of this question? Very good. So is it used in absence seizures? No, it is not used in absence seizures. Previously, there were certain disorders in which lithium was used. Epilepsy was one of them, but it is now not recommended. Okay. Other mood stabilizers, which are anti-epileptic drugs like valproate, and those drugs are used in epilepsy. Okay. Unabsorbed from the gut? No, it is in fact completely absorbed from the gut. Is not teratogenic? Again, we know it is teratogenic. In fact, we have discussed it n number of times. It causes abstain anomaly. It causes abstain anomaly. It can cause fine tremors in therapeutic dose. Yes, this is the correct answer. It can cause fine tremors in therapeutic dose. Again, we have discussed this when we were discussing lithium again. So we've talked about lithium neurological side effects. One of the side effects is tremors, fine tremors it can cause, and also you should know drug of choice for these tremors. Next time they may ask you a person with lithium having fine tremors. So what will you do? You will start propranolol. So again you should know this. So people who have to give exams in the future examinees may also note this down. So again if we talk about the tremors, fine postural tremors are adverse effects, and usually they are of the frequency of 8 to 12 hertz. Whereas another important point is severe tremors, or if the person is having coarse tremors, these are signs that maybe the person is having toxicity. So these are some extra points you should know. Is it clear to everyone? Again, I am sure this question all of you were able to mark it correctly. So many times these may appear new questions, but if you read the options you will be able to mark the right answer. Very good. Now let's take up this question. Again, this question we have been discussing. A patient with schizophrenia is being treated with clozapine. So clozapine, if you remember NEET PG, last NEET PG exam, they had asked a question on clozapine, and now it has been repeated. So these things happen. Patient has to undergo regular blood monitoring for which of the following rare side effects? So what is the right answer? Very good, Suman. Istayaq, Diksha, Abhishek, Tiruvathanam, very good. Yes, the answer. So options are myocarditis. It can, in fact, we have discussed this. We have discussed the mnemonic SAM, where M is myocarditis. So again, future examinees, should make note of it. The clinical question may be asked. Patient is on clozapine, is reporting of chest pain, shortness of breath, and there is abnormal ECG. There may be myocarditis. So myocarditis is not the answer. Seizures again can occur, but again, regular monitoring may not be required. Some students said that one of the option was suicidal tendencies. Please remember, we have discussed this. In fact, clozapine has anti-suicidal properties. Okay. Yes, wet pillow. Yes, that has also been explained, Abhishek. Very good. I'm happy that you remember that. Such questions we can expect. So this is one question that asked. We have discussed this. Intracerebral bleed can also occur, but again not regular monitoring is required. Yes, the side effect for which regular close monitoring is required is agranulocytosis. So we have again discussed this when we were discussing clozapine, and I have told you weekly monitoring for first 6 months, and then if everything is normal we have to do it every 2 weeks for the next 6 months, and then maybe after that every month we have to do that. In fact, we have to stop clozapine if WBC is less than, if WBC count is less than 3000 per millimeter cube, and if the ANC count, absolute neutrophil count, is less than 1500 millimeter cube. So these are the points we have discussed, that yes, blood monitoring is important. Okay. In fact, risk of agranulocytosis, if you ask me the risk, the first year of treatment risk is 0.73%. In the second year, the risk decreases to 0.07%. So this is, I hope everyone has marked the answer correctly. Very good. Is it clear to everyone? So all the students who are watching this video, that will be appearing for future exam, clozapine is a very important topic. Okay, clozapine is a very important topic. Now let's come to this question. The question is simple, but the options had made this question a bit tricky, a bit confusing. So let us try to make some sense of this question. A patient is having low mood, decreased interest in activities, not eating properly, and says, I am dead, I don't have a head. what is the point of eating? So did they ask you that what is the delusion seen? Can anybody tell me any modifications, if you remember anything which needs to be changed in this question? Anybody? Is this the same question which had come in the exam? Is it the same question? Look, the question seems to be fairly simple, but the options has made it a bit confusing. So because in this same question they have added nihilistic delusions and they have added Cotard syndrome. Okay, bizarre syndrome, bizarre delusion also seem, but it is more of a broader term if you talk about specific delusion. So did they ask delusion seen? If they had asked delusion seen again, so I'll talk about when it could be Cotard syndrome. Again, the answer would the ball is in the court of your examiner. Whatever they are thinking in terms of what the answer should be, maybe they will give that answer. But let's try to make some sense of this question. So the person is saying I am dead, I don't have a head. So person is negating things. So we have talked about this in the videos also. When he denies existence, a person denies existence of his body, his loved ones, or the world. He is having a false fixed firm beliefs about these things. It is delusion of nihilism or delusion of negation. And we've talked about this, that it is again, delusions can be seen in psychotic disorders and it can also be seen in disorders like depression. So psychotic depression, you can have such delusions. Now also we have learnt Cotard syndrome is someone having depression with delusion of nihilism. Now if they have asked that what is the delusion seen, they are asking specifically about the delusion. Okay, bizarre, yes, it is also seem to be bizarre, but it is a broader concept. But all the delusions you can divide it into bizarre and non-bizarre delusion. So that is a more broader concept. Again, it's an older concept which was given much more significance in DSM-4. DSM-5 has removed the concept from importance from the schizophrenia criteria. But yes, still we can divide delusion into bizarre and non-bizarre, but it is a more of a broader thing. They are asking specifically which delusion, and in the option they are giving you those delusions. So again, bizarre delusion may not be the answer, right? Now, so since they have asked you delusion, specifically they have asked you the delusion, then I feel that answer may be nihilistic delusion appears to be a better answer or a favorable answer. If they have asked you this, again many students may have different recalls, but if this is the question, it seems to be the better answer. What could have been the question if we have to choose Cotard syndrome maybe? So maybe they've given that person is suffering from depression, and and what is the phenomena seen, or what is the syndrome seen? Such type of thing if they have asked, then maybe you could have chose Cotard syndrome. Then we might have chose Cotard syndrome. Again, yes, there is some discrepancy, I agree. The ball would lie in the court, in the side of the examiner, what they would decide. But it seems from the question, it seems that they are asking specific delusion. Then it seems to be nihilistic delusion. Yes, if they would ask disorder, then maybe would have gone for Cotard syndrome. Again, it's a bit tricky, tricky question. So let us come to the answer as nihilistic delusion, and let us see if there is any changes. I'll let you know. Is it clear to everyone? Is it clear to everyone? Great. Now, next question is a 40-year-old male patient presents with emergency with persistent painful erection or priapism. I think priapism was mentioned in the question for the past 6 hours. So anybody having persistent painful erection for more than 3 hours, it is again, it's an emergency. He has history of mood disorder for which he has been on some antidepressant by the psychiatrist. What is the likely drug he is on? Yes, Dhyan. So again, we have discussed this point again in the videos also, in the lectures also. Again, bupropion and metazapine are some of the drugs which have one of the drugs with least sexual side effects. In fact, they have one of the least sexual side effect drugs. Venlafaxine has sexual side effects. In fact, trazodone was used because it would cause erection. Before there were PDE5 inhibitor drugs like sildenafil, trazodone was also used for erection, but it has a side effect that it can cause priapism. So the answer is trazodone. So again in the lectures, again I've taken it snapshot from the lectures. Again we have discussed this in the lectures also. Trazodone, one of the side effect is sedation. So it is also used in people having depression with insomnia. It is used. It has a side effect of priapism. It is a serotonin antagonist and reuptake inhibitor. Okay, it is a SARI group of drug. The side effects usually which occur are because of alpha 1 antagonism. alpha 1 antagonism, and usually the treatment. So let's just talk about few points about the treatment. Usually we give intracavernosal treatment of alpha 1 agonists such as epinephrine. Okay. Sometimes surgical intervention may be required. So this is the treatment. So the answer is trazodone. Is it clear to everyone? I think it is clear. Great. It is trazodone. Again, this has been a repeat question, but now if you see that they are giving some clinical scenarios. Okay. So when you are giving the exam again in INI CET, we already know that you have less time. So there is our anxiety. So sometimes, you know, such simple questions we also sometimes mark it wrong. So always try to, you know, read them carefully. Let's come to the next question again. This is a question, repeat topic. They have been discussing again and again in different forms. We have discussed even 2 days before the exam. We have discussed this in the revision. A patient during surgery was, given morphine, and the patient develops respiratory depression. What is the symptom? What the patient is having? Very good. What is this? So there is opioid overdose. Opioid overdose. We have discussed opioid overdose, intoxication. There is a triad of respiratory depression. There is pinpoint pupil or meiosis, and there may be coma. So what is the treatment we'll use? Very good. We'll use antagonist. We'll use IV naloxone. Is it clear to everyone? Very good. Yes, Diksha, Ishtiyar, Dhyana, Urvashi. Very good. Yes, Thiruvathanam. Very good. So it is naloxone. So this point again, if you remember, you know, just 2 days before the exam, we have discussed this point again in the video. So respiratory depression, meiosis, having opioid toxicity, there we had discussed, and the answer was IV naloxone. So again, it's a repeat question. They are just twisting the scenarios. So again, this has been, again, this was a simple question. Again, another repeat question, simple topic. We have been discussing this again and again. Tactile hallucination seen during intoxication with cocaine. So this just asks you, what is this? What is this phenomena also known as? So what is the answer? What is the answer? Dipsomania is related with alcohol. Okay, they have asked dipsomania in, you know, in INI CET before also, in match the following. Aneroid state also was there. Lilliputian hallucination, but the person is seeing small people which may be there doing some task, which may be seen in organic conditions such as delirium, more in organic conditions such as delirium. Were these the option, or anybody can remember any other option? Yes, the right answer is formication. Very good. The right answer is, all of you are correct, it is formication. Were these the options, or anybody remember any other option? I think when you see such question, you hardly remember the other options. So this is, I think, a simple question. Formication, patient experiences, you know, there are small insects crawling over or under the skin. This is, so again, used. Cocaine is a very important question for the exams. So this question has been asked repeatedly. Many questions on cocaine have been asked. Which of the following is not a symptom with cocaine use? Okay, speedball again is an old question on cocaine. Okay, so cocaine has been asked. A patient having tachycardia, you know, again hypertension and scratch marks. What substance is using? Cocaine we know is a stimulant, and scratch marks may be because of tactile hallucination. So these questions have been asked again and again. Okay, maybe option D was different. Okay, okay. So the one option was okay, carphologia. Okay. Okay. So, okay, so then again the answer is A. Okay, so we'll modify. Very good. So again we are trying to get the better, you know, all the options. If we can collect the right ones, maybe, you know, when we'll update in the video, we'll add them. Very good. So thank you everyone. So I think this is formication in this question, right? So this again we have discussed in the video. Again we have discussed, also known as cocaine bugs or magnum bugs. Scratch marks may occur in the physical finding. Great. Let's come to the next question. Again, this is an interesting question. Let's try to make some sense of this question. Okay, again let me know if there are any changes in the option, any changes in the question. Again, alcohol they are asking. So now they have just made a new question of alcohol, not asked I think previously. A patient is brought by the police during examination. Person smells of alcohol, has conjunctival congestion or red eyes, but he is conscious, motor coordination is normal, can walk in straight line, and he talks normally. Which of the following statement is true? Is the question correct? It is the exact question. Okay, Devesh is saying the question is correct. Okay, so this is the question, and please just have a look at the options and let me know if any change in the option. So they have a patient, we have a patient who is smelling of alcohol. There is congestion in the eyes, but when we are performing certain tests, all the tests seems to be normal. We are asking him to speak, we are doing some some test, and everything seems to be normal. So it seems very good. So what would be the answer? Very good. So it seems, so look at these two options. One is patient has not consumed alcohol. That does not seem to be the scenario because it appears that he has consumed alcohol. Okay. Now, so the options, so please let's look at the option. Rest three options are saying that he has consumed alcohol. Right. Now, what are we dealing with? We are basically trying to see, so when we say that he is under the influence or not under the influence, is the alcohol has started affecting the person. So we are talking about impairment which may be occurring because of alcohol intoxication. So indirectly they are asking, does the person appears to be intoxicated with alcohol? So again, you know, if you see the videos, we have talked about the levels of impairment with different blood alcohol concentration, and we have discussed this, that 20 to 30 milligram per deciliter there is slow motor performance, maybe decreased thinking, but also legal limit of drinking in India is 30 milligram per deciliter. So at the till this limit, maybe the person is, you know, there is not significant impairment. If you look at when the blood alcohol concentration increases, if you look at the impairments, so patient may start having motor and cognitive problems, incoordination, mood lability, nystagmus, slurring speech, blackouts may be there, amnesia, vital signs may get impaired, and possibly very high, when more than 300 milligram per deciliter there may be death. So they are talking about intoxication. And when we talk about intoxication, when do we say that someone is intoxicated? So there should be recent intake which is there in the question. There should be clinical significant problematic behavior or psychological changes. The question does not mention any of such changes. There should be signs and symptoms. Now look at this, they are saying that the person speaks normally. So it, you know, it says that there is no slurred speech. Impaired attention memory is also, you know, because it seems that he is talking normally. Also, if you see the other options, incoordination, unsteady gait, nystagmus, stupor or coma, all these, you know, again with more rising blood alcohol levels, these may occur. So they are trying to tell you that motor coordination and also speech seems to be normal. So is it a case of intoxication? So indirectly if I ask you, is he under the influence of alcohol? It seems he has consumed alcohol, but is he under the influence of alcohol? That seems to be the, so what would be the right answer? The right answer to this question will be B. He consumed alcohol, but he is not under the influence of alcohol. So all the things which are, you know, you are tested, everything is come out to be normal, is trying to tell you that he is not intoxicated. Is it clear to everyone? Is it clear to everyone? I hope, you know, this seems to be clear. If there is any, you know, any, so options were, I think options were correct. If you could see the options, were there any changes in the option? This seems to be the likely answer. Okay, is it clear to everyone? Great, great. Let's come to the next question. So again, you know the concept, you have to just apply in these questions. Again, this is a fairly simple question. Just let's have a look at this question. Same, right, same. Okay, great. Let's come to the next question. Anybody remembers anything of the previous question, any changes, just let me know. We'll try to modify them. Okay, let's come to this next question. Which of the following is included in the criteria of substance dependence? Option A is gradually increased amount of drug is taken over time. B is consuming despite harmful, you know, physical harm. C is prefer substance over other activities, and D is tolerance. What these the options? Option A and D would appear the same. You know, there is development of tolerance, so more amount is now taken over time. Right, right. So are the options, is the question the same, or any changes in the options first? Yes, question seems to be, you know, clear that yes, all of these seem to be the criteria. So the answer is C. All four options are correct. The criteria of substance dependence. Any change in the option? Same. Okay, Diksha is saying it is same. Okay. Yes, very good. All of you are marking it correct. It was same. So if this was the question, it seems to be again fairly same. Again, we have discussed this again in the app as well. We talked about dependence criteria. We've talked about dependences when there is a strong desire to take substance, there is craving. Difficulty in controlling substance taking behavior. Withdrawal symptoms, very important. Withdrawal symptoms, they are unique for different substances. Development of tolerance, increased amount required to get the desired effect. Then progressive neglect of alternate pleasurable activities. Person spends more time in substance use, and person continues to, you know, use substance despite clear evidence of its harmful consequences. So these are criteria of dependence. So right, is it? So everybody has seen it is all. So option A and D seems to be same. Development of tolerance, right, it seems to be. So the answer is all. Okay, so answer seems to be all. Was all option there in the question? All option was there in the ABCD. Was that option there in the question? Can anybody know? Let me know. Were there option, saying that yes, all are correct? So then that seems to be the best answer. Yes, it was there. So right, it is the answer. Now let's come to the last question. So this question, in fact, this question I would say, we had not discussed. In fact, it is an old question. It went under the sand, and again it has again resurfaced. Again, we have been discussing about this topic even before the, 2 days before we have talked about eating disorder. We were thinking that eating disorder questions may come. So I've been talking about some newer questions like refeeding, complications, but they have asked a question on a screening tool, SCOF. So this is a screening tool. SCOF questionnaire is used for evaluation of. So please see the options. So were these the right options? Yes, the answer is eating disorder. The answer is eating disorder. So eating disorder, again I would say the topic, we have been focusing on this topic, but yes, a twisted question have been asked. It's an old question, I think, of Nimans. So they have asked again. So again, in fact, in NEET PG 2019, if someone remember, there was a question on confusion assessment method. These questions they ask sometimes. So again, such questions can resurface again. Okay, so confusion assessment method we have discussed previously. It is seen in delirium. So this answer is, so what is cough? So basically we ask 5 questions. One is, do you make yourself sick because you feel uncomfortable, you feel uncomfortably full? Do you worry that you have lost control over how much you have eaten? Have you recently lost more than 1 stone? 1 stone is 14 pounds somewhere, around, it is around 6.35 kgs of weight in the past 3 months period. Then next is, do you believe yourself to be fat, and would you say that food dominates your life? So this is cough. So this is cough. So this question, these questions are asked, and every one question, if the person says yes, 1 point is given. So 2 or more points. So if the person says yes to at least 2 of these 5 questions, we say it is suggestive of bulimia nervosa or anorexia nervosa. It is suggestive of eating disorder. It is a screening tool. It is a screening tool. Okay. So yes, this question we have not discussed. Otherwise, rest all the 11 questions we have discussed, that's there in the app as well. So I hope, so any doubts in any of the questions, please let me know. Any doubts in any of the previous questions. Again, just a small message, those who will be appearing, some of the future examinees would also be, sitting. So, few things from take home message from this, these questions of psychiatry. First of all, again, there is a good number of, 12 question is a good number. Focus on the concept. So many times, we've been focusing that, focus on the concept. Practicing MCQs is very, very important, because many silly mistakes occur because we have not practiced enough. Also, speed is a limitation. A lot of questions were having more than one option as correct. So speed matters a lot in such exams, especially INI CET, when the time is even less. And previous year's topics are very important. If you see overall, all the topics, they were, again repeated. Some new question, new drug was there, of course, I understand, but yes, we have discussed that. Luckily, we had discussed that, so it should not be new question for you. Okay, so these are some, tips for that. And those of you who have given the exam, they have got good rank in NEET PG exam, the last exam, and they are just, waiting for their, rank. So I would say that, enjoy this phase, and for rest of all who will be giving the exam in the future, keep smiling, keep moving forward, you will do well. Okay, so I think we can conclude this session. Anybody has any doubt, you can ask. Otherwise, we'll conclude. Okay, so thank you everyone. May God bless you all.
Hello. Hello, student. Good evening to all of you. Just check whether I am audible and visible to you. Good evening, Dr. Ankit. So I am completely and clearly visible and audible to you or not? Just give me a thumbs up. Clear at your end? Good evening. Good evening, Dr. Ishaq. I am audible to you clearly? Yeah, thank you. Thank you so much for the confirmation. Right. So, good evening, doctor. Good evening to all of you. So, as you know, ki recall session going on. So, INI CET recall, I am going to discuss the physiology questions and their possible answer. And all of you know, I am Dr. Soumen Manna, your physiology teacher. So, before discussing the questions and their answers, first these two disclaimer that the question that we are discussing here is only recall based question, and this is just for getting the actual question which is asked in the examination. So, you can easily comment in the comment section if you feel that some options are not correct or the stem of the questions are not correct, so that we can get the actual questions and it will benefit a huge number of students later on, right. And the second that is final question that will be received after the discussion will be uploaded in the Prepladder app, right. Okay. So, we will start the actual discussion, but again I am saying because this is a recall session and I am not going to discuss the detail or in-depth discussion of each and every question. I will only tell you the answer and little bit about the explanation. Okay. Now, if you analyze the INI CET questions, particularly the physiology, there are altogether 12 questions has been asked from physiology, right. And there are another 2 questions are there which is overlap between biochemistry and other subject like medicine and all. So, here I have kept 12 questions. If you analyze these 12 questions, you will find out that they have asked pure questions. 2 questions has been asked from the respiratory physiology, 2 questions has been asked from CVS, 2 questions general physiology, neurophysiology including the nerve muscles and central nervous system, 4 questions are there. Okay. So, the central nervous system questions are very less this time, nerve muscle questions were there too, and 1 question has been asked from GIT and 1 question is from endocrinology. So, this proportion of question is more or less same with that of the previous year. If you analyze the previous year question also, you will also see this kind of distribution is there, the respiratory and CBS will be 2 type of questions. So, altogether 12 questions have been asked from physiology. Okay. So, we will be discussing those questions with their answer, right. Now, some of the questions that I have kept here, complete options I did not get from the student. Okay. So, you can contribute the options if you recall in the chat boxes. Okay. Next thing is that among all these 12 questions, you know, if you analyze the questions, 4-5 questions are a little difficult side. Okay. And all of you are giving your explanation that this time INI CET was a little bit hard. I do not know about other questions, the other topic, but in physiology 4-5 questions was really little bit difficult, but the other questions are easier one, right. Okay. Let us see. So, first question I am showing you here, this is the first question, relaxation pressure is 0 at which of the following lung volume. I believe this was there in the question, right. Yes. So, physio 4-5 questions were little difficult. I will show you that does not difficult at all, but in the examinations hall, you know, the some of the questions looks very difficult. Okay. So, first question here, relaxation pressure is 0 at which of the following lung volume. Now, if you follow my lecture, I have discussed this question multiple times that FRC is known as the relaxation volume of the lung. So, in this question, without thinking anything, right, you can directly keep your answer, you can directly take your answer that it is nothing but the FRC, because FRC is known as the relaxation volume of the lung. So, the same questions, okay, same question has been asked in a different format, that the relaxation pressure is 0 at which of the following condition. So, the meaning of this question, that at FRC, the elastic recoiling of the lung tissue, we know that elastic recoiling of the lung tissue is opposite to the elastic recoiling of the chest wall. So, at which volume these two forces become equal to one another, so that the relaxation pressure will be 0, and the answer of this question is FRC. So, the first question here, answer is FRC, right? Okay, very good, Dr. Istaq and all. Now, second question. Okay, so this question I have discussed in rapid revisions. In Prepladder app, if you follow the rapid revision, there are certain image based questions that I have discussed, snapshot. From that snapshot, the question has been asked directly. So, I will show you first that what I have discussed in the actual Prepladder app. So, this was the question that I had discussed already in rapid revision, okay, where I have discussed these two types of curve, that how to differentiate that this is anemic hypoxia or different types of hypoxia. So, I am going back to the question that has been asked here. So, I believe that this is a type of curve they have given you in the question, and they asked that the curve X indicate which of the following type of hypoxia. Is this the type of question they asked, okay, with this image? Because some student told me that this was the kind of image that was given in the question. Yes, right. So, see here carbon monoxide poisoning was also there in the option or not? Okay, okay, Dr. Diksha, carbon monoxide poisoning was also there in the choices, or hypoxic hypoxia was there in the choices? Carbon monoxide poisoning was there in the choice option, could you recall? Okay. Anyway, good. So, carbon monoxide poisoning was also there in the choices. So, this question is very easy. Why easy? Because if you look at the x axis, I told you repeatedly that always look at the x axis, whether it is saturation or whether it is oxygen content. So, x axis is the partial pressure of oxygen and y axis is the oxygen content. So, y axis oxygen content mean we all know that if the oxygen content of the arterial blood, that is around 20 ml per deciliter of blood, we know. So, this is the normal, this is the normal oxygen amount in the arterial blood in a person where partial pressure of oxygen and hemoglobin is normal. So, this is the normal person. Now, if we look at the curve X, so what we are finding out here, that the oxygen content is very lesser than that of the normal person. So, the oxygen content is very lesser than that of the normal person. So, two things can happen, it can be anemic hypoxia also, carbon monoxide poisoning also. The only difference between these two curve, in both the cases the oxygen content will be less, but in case of carbon monoxide the curve will be on the left hand side of the normal curve, because we all know that carbon monoxide poisoning shift the oxygen dissociation curve on the left hand side, right. So, this blue color curve is the typical curve of carbon monoxide poisoning, and here the curve, I believe that the curve is following the normal curve, but the content of oxygen is below normal. So, this is typical of anemic hypoxia, right, not the carbon monoxide poisoning. Other two, stagnant hypoxia, histotoxic hypoxia will not be the answer here, because here the oxygen content will be normal like that of the arterial blood. You know that stagnant hypoxia and histotoxic hypoxia, arterial blood oxygen content remain normal, means the curve will follow that of the normal curve, but we all know that the diagnosis of this stagnant and histotoxic hypoxia is done by measuring the artery venous oxygen difference, right. It was on the right hand side. So, the typical hypoxic hypoxia was the option instead of carbon monoxide poisoning. Then if it is hypoxic hypoxia without carbon monoxide poisoning, then there is absolutely there is no confusion that the curve is going to be anemic hypoxia, right. So, obviously the answer will be anemic hypoxia. If the carbon monoxide is not there in your choices, anemic hypoxia is the sure shot answer. But look at this is the curve that I have shown in my lecture class also, that look at here, this is the normal curve, this is the curve from the normal person, and this is the carbon monoxide poisoning curve, and this is the anemia curve. So, look at here, the anemia curve is a little right shifted from that of the normal person, and the carbon monoxide poisoning curve is a little bit left shifted that from the normal curve, right. So, this way the two curve is differentiated. Okay, anyway, so if the carbon monoxide poisoning was in the option, then obviously this histotoxic hypoxia will not be there in the option anyway, but hypoxic hypoxia, even if it is there in the option, this will not be the second curve. This curve is typically low oxygen content in the arterial blood, either anemic hypoxia or carbon monoxide poisoning, because both of the thing, carbon monoxide poisoning also causes anemic type of hypoxia, but the differentiation between these two curve, one will be on the left hand side, right. So, this way here the answer will be anemic hypoxia. Okay, fine, perfect. So, this I have discussed in snapshot. Now, next question, which of the following statement is true regarding skeletal muscle contraction? Now, this is one question which has been repeated, this is the third time. The same topic, the INI CET is giving multiple repetition from the same area. Now, if you say this is not the exact repeat, yes, I believe, but whenever I have discussed this kind of questions, I discuss the DHPR and RYR coupling between skeletal muscle and cardiac muscle, clearly I have discussed, right. Even in the rapid revision portion also, forget about the main lecture in detail I have discussed, forget about the main lecture. This is the screenshot I have taken from the rapid revision part, right. The skeletal muscle and the cardiac muscle discussion I have done separately and clearly. So, here is, as you can find out here, I have written here that the source of calcium for skeletal muscle contraction is 100% source, and that is where from it is coming from sarcoplasmic reticulum. So, skeletal muscle does not require the ECF calcium. ECF calcium is not requiring for skeletal muscle contraction. So, with this concept, if you look at which of the following statement is true. So, skeletal muscle contraction occurs via intracellular calcium. Yes, 100% calcium for skeletal muscle contraction is intracellular. So, this is absolutely true statement. Extracellular calcium is essential. So, obviously, this is a false statement, right. If I am not wrong, something else was given in question, mammals or something can proper recall. Okay. So, even if it is mammal also, mammalian skeletal muscle all behave like same, like that of the human also, right. Okay. So, calcium release occur from mitochondria, this is also not required for skeletal muscle contraction. Voltage gated calcium channel opening, so this is talking about DHPR. DHPR opening is required for cardiac muscle. DHPR opening is required for cardiac muscle, not for the skeletal muscle. So, this is also a wrong statement. So, only option that is correct here is the option number A, and this is our answer. But again, I am saying that if you could recall the better option or the better stem for the question, like here Dr. Diksha is saying ki some additional term was given in the question. Obviously, it may be there because it is a recall based, but more or less the question was like this, that they were asking that what is the concept of skeletal muscle contraction, what is the source of calcium. So, if you only know this thing that DHPR and RYR, there is electromechanical coupling is there and 100% calcium is released from sarcoplasmic reticulum, then it will be easier for you. The question was different regarding skeletal muscle contraction. So, options were different. Okay. So, could you recall? If you could recall the options, please do post in the comment box. I will later on correct the options, right. But for the timing, you are also not able to recalling the options, and I am in a very bad position because I do not know what was the actual choices. So, this was the recall given by some of the student. But obviously, if you have better recall, please do put in. The one option was calcium released from sarca instead of intracellular. Okay, calcium released from sarca, this is not correct because sarca is the pump which mop up the calcium, it is not released. Okay. So, if it is also there, that is very good. So, sarca pump will be here near. So, sarca pump will be here, and the sarca pump is for mopping up, means calcium will be taken up from cytoplasm through sarcoplasmic reticulum. So, that is not for release. For the release, RYR will be the true option. Very good, very good. So, one option was calcium released from sarca instead of intracellular. So, that is also a false statement, but you have to choose an option where they are explaining that calcium release from sarcoplasmic reticulum or calcium release from intracellular organelle, 100% source of calcium from intracellular source. That will be the answer actual. Okay. But sarca is not for release, RYR is for release, right. So, that way if you could recall, I am telling you again and again, please do post, right. Now, next question, I believe this is one of the easy question. I hope all of you have correctly answered, okay, because this is a pure question based on the structure of sarcomere. And if you are reading from any of the platform, forget about our platform, if you are reading from any of the platform, I believe this will be explained by every teacher. And all of you know the structure of sarcomere. So sarcomere, this will be the Z line. So if you start from periphery to center, okay, so Z line will be there, and then this A band, that is the myosin. So first you will encounter this Z line, then you will encounter this A band, then some portion of the A band which is lighter, which is known as the H band, and at the center of this sarcomere there will be M band. So some of the students, they are saying the question was from periphery to center, and some of them believe that question was from center to periphery, okay. But here I have put from periphery to center. So from periphery to center means first Z, then A, then H, then M, right? Right. So first Z, so Z is this, okay. So this is number 1, okay. Then followed by A aega, so this 3, 1 after 3. So first this, then this 3, then will be H 4. So option A is correct. So this will be my answer, okay. Sure, from periphery to center, very good. So periphery to center, confirm, right, very good, thank you so much, okay. Now this question, obviously I told you any teacher will explain in their class, and even in my class also I have explained with the full name of all this band and their structure with electron microscopy structure, everything has been discussed. I believe you have read the main lecture, okay. So now Wien-Kessel effect is not shown by, so Wien-Kessel effect is not shown by which of the following blood vessels. Now whenever we discuss Wien-Kessel effect, we say that Wien-Kessel effect is seen in vessels which contain huge number of elastic tissue, right. And we describe that obviously elastic tissue is maximum in the arch of aorta. So arch of aorta will have the Wien-Kessel effect along with the branches from the arch of aorta, which are large blood vessels. They contain huge number of elastic tissue. So obviously if you look at arch of aorta, will have the Wien-Kessel effect, obviously, okay. Carotid artery, branch of this, they will also have this, okay, and subclavian will also have this, okay. Coronary artery instead of subclavian. Radial was also there, coronary was also there, okay. Are you 100% sure? So in these choices, radial artery will be the answer, because radial artery is a smaller artery and it's a peripheral artery. So if you look at here, aorta, carotid artery, subclavian artery, all of them will have thick elastic, okay, tissue. So they are the thick artery. So they will have the Wien-Kessel effect, but not the radial artery. Even if the renal was in the choices, then also I will go for the radial artery, right? Because renal artery is a thick artery and the elastic tissue will be much more there. Huge amount of elastic tissue and huge amount of smooth muscle was there. Okay, so I will change this subclavian with the renal artery, as you are saying, right? Renal artery, I will change this option. Very good. So in that cases, your answer will be radial artery, right? Okay, fine. Okay, so Wien-Kessel effect again I have discussed in my lecture. So this is the image from that actual lecture. I am not taking much of the time here. So the next question here, now here I require your help. So I got one question that students are saying that change of blood pressure at the radial artery during a Valsalva maneuver. So there was a question on Valsalva maneuver, and one diagram of the blood pressure recording was given, okay. Now here the diagram that I have kept here is something like this, but what was the actual diagram? There was a single line diagram or this kind of diagram was there. Could you recall the question on Valsalva maneuver? This kind of diagram was there or single line diagram was there? This I guess, okay. So if AIMS is basically putting question, they will not give you the single line diagram. They are particularly going to give this kind of diagram. Anyway, so see, two kind of diagram can be given. So if you follow this diagram, option was different, okay, okay, okay. So dekhte, I will tell you the answer. So there is a line like this. If you follow this dark color line, then you are going to find out a recording of blood pressure like this. So although the diagram which I have put, I have kept here, this is taken from a journal article, right? here what you are finding out, here you are finding out the systolic blood pressure and diastolic blood pressure, systolic blood pressure and diastolic blood pressure, fluctuation of blood pressure, they are showing. But if you follow this BP recording, follow this blood pressure recording, then you will be finding out a dark color line in between, right. So, that is more or less your mean blood pressure. So, if you follow this, it is like this, okay. See, it is like this. So, this is the typical fluctuation of blood pressure, okay, typical fluctuation of blood pressure, which is nothing but your happening during Valsalva maneuver. So, what happens? There are 4 different phases. Phase 1, where there is increase in blood pressure, right. Phase 1 is the increase in blood pressure, as you can finding out here, right. Then phase 2, phase 2 is the sustained decrease in blood pressure. So, this is the phase 2, sustained decrease in blood pressure, this part is the phase 2. Then there is again a decrease in blood pressure, that is the phase 3. So, this is the typical phase 3, and then there is increase in blood pressure and stabilization of blood pressure, this is the actual phase 4, right, this is the phase 4. So, the actual question that they were asking here, that what is the reason of the increase in blood pressure during this phase 1, initial phase 1 बोला नहीं था, but I believe that question was actually what is the cause of increased blood pressure at the start of Valsalva maneuver. That was the question, that increase in intrathoracic pressure, which increase in left ventricular and increase in outer, okay, right, okay. So, if this is the options as Dr. Roshan is saying, then I will also tell you. So, first, Valsalva maneuver means whenever you start straining against a closed glottis, that is a Valsalva. So, you have a closed glottis and you are putting pressure on your thoracic cavity. So, what will happen? Whenever the thoracic cavity is putting pressure, there will be squeezing out of the blood, from the, okay, squeezing out of the blood from the pulmonary vessels into the left ventricular chamber, okay, and that squeezing out of the blood from pulmonary circulation to left ventricle will increases the cardiac output, and that will increase your blood pressure. Getting my point? Okay. After that, whenever you put pressure in sustained pressure for 10 seconds, what you do in Valsalva maneuver, you first start initiating the pressure and then you maintain the pressure for 10 to 15 seconds. So, whenever you are maintaining the pressure, then that is a phase 2, means there will be decrease in blood pressure. So, this decrease in blood pressure in phase 2 is due to decrease in venous return. But what was the cause of this increased blood pressure at the onset of Valsalva maneuver or at the onset of straining? There is increase in intrathoracic pressure, and that intrathoracic pressure is compressing the aorta and pulmonary artery circulation. This increased compression on aorta and pulmonary artery, what will happen? The blood will be squeezed out from the lung into the left ventricle, and that will rise your blood pressure. So, getting my point? So, it will be your increase in intrathoracic pressure. That increase in intrathoracic pressure will causes compression of the aorta and pulmonary circulation. This will be the actual answer. So, there was an increase in intrathoracic pressure, ये answer होगा, with increase in left ventricular or increase in aorta pressure, right. So, whenever there is initially increase in intrathoracic pressure, pulmonary vessels will be squeezed out, that will drain extra blood on the left side of the ventricle, and that will rise the blood pressure. So, the first option is the answer here in the question, or even if it is not there, actual answer, if it is there in the increase in intrathoracic pressure, then you have to choose that one only, right. One option was increase in left ventricular and one option was increase in aorta. So, increase left ventricular and increase intrathoracic pressure, you are saying both were there in the choices. Okay, Valsalva maneuver mean obviously there will be increase in intrathoracic pressure, okay. Intrathoracic pressure increment will causes increase in left ventricular blood volume, that will be your actual answer. ठीक है, right? I hope you got the concept. Let's see what others are saying, what was the 4 different choices. But by the time this question I have discussed in snapshot or the rapid revision part, the exact diagram that I have discussed in my snapshot was like this, okay. So, this is the same diagram like that of the Valsalva maneuver, okay. Okay, आगे बढ़ते हैं. So, which of the following is an incorrect match? Look at the options. Again, there are certain confusion whether the options was exactly like this or options was something else. Now, if you go on analyzing these options, okay. So, here you are finding out that gastrin, G cell of the stomach. Absolutely true statement. Okay, because gastrin is secreted by the antrum portion of the stomach, right? Motilin, right? It is secreted by emo cell from duodenum and jejunum. Yes, emo cells are present in the stomach, duodenum and jejunum. Sir, in C, duodenum and jejunum was given. Oh my God. So this is also true. Okay. CCK, right? So CCK is secreted by eye cells of the small intestine. Absolutely correct, but not the pancreas. So this pancreatic part is not correct here. G cell from antrum. Okay, so G cell from stomach, yes. C, duodenum and jejunum. Okay, and secretin is from the S cell of duodenum and jejunum. This is also true. So from here, C will be the answer. But if you are saying CCK secreted from duodenum and jejunum, then that is also a true statement. Then you have to look at the other options, whether this was the exact option or something different was there, because motilin is secreted from the emo cell of the duodenum jejunum. This is also correct. Or someone is saying that motilin emo was not there, M cell was there in the option. So if it is the M cell only, so emo cell and M cell is different. Okay, M cell in the GIT, they are known as the microfold cell, antigen presenting line cell are there. So whenever we say only M cell, that is a microfold cell, and if it is the emo cell, then that is the correct for motilin. So now if you are saying that CCK is secreted from duodenum and jejunum was there, then it will also be a correct statement. Okay, and then motilin from M cell, then that will be a wrong statement, means then it will be your correct choices if rather than MO if it is only M cell, because M cell is the microfold cell. They are the cells which are responsible for the immunity of the GIT part, they have some role. So if only M was there, then you have to choose that one, but before that you have to make sure that it was not the pancreas, because the question that given by some student that CCK is secreted by duodenum and pancreas. CCK has action on pancreas, but it is not secreted from pancreas. So if this is the scenario, then I will go for this option number C. But if C is duodenum and jejunum, right, and motilin is only M cell is given in the choices, then I will go for motilin is not secreted by M cell, it is a MO cell. Only M was given. I think MO nahi tha, only M cell tha, then that will be the false statement here. Okay, but again I am telling you have to make sure that pancreas was not there in this choices. Okay, anyway, so I hope you got this. There will be answer between these two. That's why the students are saying the question was difficult. Okay, now I can understand. That's why the students were saying the question is difficult. Okay, so there was very little differences. Okay, so generally we teach this thing in classes also. In my lecture also I have discussed all this thing, that G cell from I cell and S cells, and also I have discussed the motilin during the migratory motor complex chapter. Okay, so anyway, next question, hormone synthesized by smooth endoplasmic reticulum. I think this is one of the most easiest question, which is a question of PMT, and all of you know the smooth endoplasmic reticulum is for the steroid biosynthesis and the rough endoplasmic reticulum for protein hormone synthesis. So I hope all of you have done this question at least correctly. Okay, so no further discussion is required here. Okay, fine. Now next question, again this is one of the easy question, although in my lecture it is not there. Okay, that alkaloid the beta test is given, but I think by after reading pharmacology, after reading forensic medicine, all of you know that the alkaloids is nothing but a beta test, right? So alkaloid is beta test. So again not much discussion is needed here. Peptides generally sweet hota hai, but it can be other test also. Sodium is salt and hydrogen ion is a sour test. All of you know this thing. So A is the clear cut answer. FMT choices, right? And in Genong this kind of table has been given, right? So where you can find out beta test is the strychnine hydrochloride, is a very beta test, and all of you know that from your forensic medicine and your pharmacology knowledge, right? Okay, so I am going to the next question. Now next question here is the identify the neurological test performed at the image given below. I believe the medicine teacher will also discuss this question, but this was a clear cut question, and all of you have given correct answer, I believe, Hannah. So neurological test, as you can find out here, the plantar response is performed, and the response that is given here is the dorsiflexion of the great toes and the fanning of the other toes. So obviously this is the Babinski sign. ठीक है ना, right, Babinski sign, okay. So why are you saying the tough one? 2-3 questions are tough, but these are easy questions, okay, and you have marked correctly, right? Okay, very good. Now there was a question on Nernst equation. Is it there? There was a question of assertion reasoning type of question on Nernst equation, but the student whom I have asked about this question, okay, it was the easiest, right? So yes, this was a question, okay, but could you recall the options? Even if you could not recall at present, please put in the comment boxes that what was the options on Nernst questions, right? And I hope you have done the question correctly, but I didn't get anything about the this question, Nernst equation, that what was the option, what was the assertion, and what was the reasoning. Sir, it was about RMP. Okay. So yes, so Nernst equation and RMP, there must be some comment like this, but if you could recall anything about this option, please put in the comment box. I will correct this question later on. So right now discussion is not possible on this, but please put the question correctly. Okay. Now next question, which of the following hormone act through JAK-STAT pathway? Now here whenever we discuss JAK-STAT pathway, okay, we generally say that growth hormone and prolactin, they have JAK-STAT pathway, okay. So basically tyrosine kinase and tyrosine kinase pathway ke baad we have to remember that whether it is JAK-STAT pathway or the MAP kinase pathway, okay. So JAK-STAT, MAP kinase, this kind of pathway I have also taught in my lecture also, and in lecture we generally say that JAK-STAT pathway, two famous hormone that you have to remember about growth hormone and prolactin, right? But you know, if you get this question in exam, it becomes a little difficult because it's not a direct repeat, okay. Okay, but if you go on excluding this option, so aldosterone, are you going to mark it? Answer is no, because it's a steroid hormone, so obviously JAK-STAT pathway ka koi baat hi nahi aata, okay. Second, this calcitonin and vasopressin, whether it is vasopressin V1 or V2 or V3, whatever, this is nothing but a G protein coupled receptor, right? And this is also G protein coupled receptor. That's why in my lecture I told you repeatedly that please follow two tables, one of the table from the rapid revision only, okay, the main lecture also, and in the rapid revision also I have shown this table, that please remember this G protein coupled receptor and the receptor which act through the other pathway. Like for example, here you can find out the calcitonin option is given, the vasopressin receptor V2 is also given here, and the vasopressin receptor V1 is also given here. So see, all this calcitonin, all this vasopressin or ADH receptor, they are acting through the G protein coupled receptor, and I told you that this JAK-STAT pathway, they are the receptor which act through the tyrosine kinase pathway. So only options remaining here is the leptin, right? So generally regarding leptin, we read, yes, by rule of exclusion you will get to know the answer. So generally leptin, what we remember that permissive action in puberty, that generally we remember. Now this time AIMS has asked that what is the pathway activated by this leptin. Now there are many such substances where you will not be able to remember the exact pathway which is activated by those hormone, but what you have to do, you have to go by exclusion, and this is the way that you have to exclude here, that all of these hormones are either G protein coupled receptor or steroid, so they are not going to be your answer. Only answer is possible is leptin. So I think this was more or less the question that has been asked in physiology questions, okay. And another question was also there, I think, thermic effect of food, that which food has a maximum thermic effect, that has been discussed in biochemistry also. And there was another question on anion gap, I have seen that has also been discussed in biochemistry question discussion. So that way I have not kept those questions in my lecture, but this is altogether what has been asked in physiology. Total 12 questions, okay. 4-5 questions was a little difficult, and rest of the questions are easy or more or less, I mean, normal expected question, right? So this was from my side. So student, I am requesting you, please, if you could recall the options, particularly the questions on Valsalva and the questions on Nernst equation, please put in the comment box. I will later on collect the options. Thank you so much. Bye bye. Take care.
Hi guys, a very good evening to all of you. I hope you had a very fantastic examination and all the questions which were there, you did them correctly. Pertaining to anesthesia, unfortunately, there were only 2 questions. But I guess in the last moment when we were revising the things, I asked you to put some emphasis on few points. And in that, I told you, I requested you to have a look at the ACLS and the BLS guidelines, because now it's become very frequent these years that questions are being asked from these CPR guidelines. So basically, that was a pretty easy question for you, because in that ALS guidelines, the tables have been made separately, which tell you about the quality of the CPR which is being given. They didn't go into the details of the CPR. So they directly asked you the first question, which I have come through from you students only, that which of the following statements is incorrect pertaining to CPR. Now, guys, as you all know that the depth of chest compressions should be around 5 to 6 centimeters for a good recovery of the patient. You have to allow the proper chest recoil. And in the points also, I told you that the rate of compression should be between 100 to 120 per minute, whereas the chest compressions should be in a ratio of 30:2. And that is the most relevant point which you have to keep in mind, that whenever you are giving chest compression in an adult, because they have asked you only about adults in this question. So the correct question in this, correct answer in this question was to perform 15 to 20 chest compressions, which is wrong. You have to perform chest compressions in a ratio of 30:2. They didn't go in the details whether the patient is intubated or whether the patient is on any advanced ventilation. They just want you to understand that what are the different methods or different things which you can do to improve the CPR of the patient. So this was a rather easy question pertaining to your examination. The second question, I'm very sorry for you guys to have such an unfortunate question in your examination, because I personally feel that these types of questions do not give you detailed information about the patient, about the case scenario. Now, many of you who have given the examination just after your internship, or you might have done your junior residency, might not have been posted in anesthesia or in ICU for a longer duration, right? And I know that whenever you are posted in a ICU setup, you don't tend to get so much into the patients while you are having your duties. I still understand that the posting in anesthesia is just for 15 days. In that, you might get a chance to get posted in an ICU. But I personally don't feel that this question is correctly framed for you guys, because there are many things which are missing in this question. And till the time you get to a diagnosis for this patient, see, now guys, ventilator is a very complicated machine, right? You just cannot ask a doctor to just change one setting and improve the parameters of the patient. But still, what I have tried to do, I have tried to solve this question. It doesn't make sense in my point of view. But they have asked you that there was a patient who was on a ventilator. First of all, in this, the age of the patient has not been mentioned. The diagnosis of the patient has not been mentioned. Whether the patient is having any ARDS-like symptoms or the patient is having any other respiratory disorder, they haven't mentioned anything pertaining to that patient in this scenario. They have just mentioned that the patient is having some kind of asynchronous respiratory pattern, right? Now, that means that the patient is not in synchrony with the ventilator. There is a VQ mismatching happening at this time of point. Now, they did an ABG analysis of the patient in which they have given some details to you. That first of all, they have said that the pH of this ABG was 7.3. That means it is going towards acidotic picture, right? Now, in this component, they haven't mentioned anything about the metabolic component, and that is why there is no compensatory phenomena happening in this ABG. Now you can see that the CO2 is 48, which makes it a respiratory acidosis, right? Now this, till this time, I think this is clear to you guys that this picture is going towards respiratory acidosis. Now you can see the oxygen parameters of this patient are normal, right? Guys, don't go on the values. They might be wrong in this. Just think of that the CO2 of the patient is rising and the O2 concentration of the patient is almost normal, right? The peak end expiratory pressure, which is there, is kept at 10 millimeters of mercury. Now that means that they are giving enough PEEP to that patient to keep the alveoli open. Now, why I said that I don't like this question, because if you knew the pathological underlying pathological condition for this patient, there can be many variants to this, right? Now, let's say that the patient is not having any ARDS condition. If they would have mentioned that the patient is having any kind of ARDS symptoms, you would have directly gone to the option C, that is increase PEEP to 14, right? Because we increase the PEEP in only those scenarios. But they haven't mentioned any ARDS, like acute respiratory distress syndrome, in which the alveoli tend to collapse, and if we have to give more and more pressure for gaseous exchange, right? Now the tidal volume is 480 ml and the FiO2 is 100%. Now guys, in the option they have mentioned, the first point which I would like to say, now guys, in your examinations, just forget about these things, like it used to happen in earlier examinations, that if they have given an option like none of the above or all of the above, they tend to be correct 50% of the times. But I have seen in the previous patterns that 90% of the times, this option is not at all correct. This option is not at all correct. So looking at the options which we have, what we see that if we decrease the respiratory rate, what we learned in the, if you would have used a bit of logic in this question, you would have, you remember that when we were talking about the capnography, when we said if we decrease the respiratory rate, we tend to increase the CO2, right? We tend to increase the CO2. Now in this scenario, we are planning to reduce the CO2 because the oxygenation which we are giving is almost fine, but the FiO2 is pretty high. That is fine. We are going to reduce it gradually. But the oxygen concentration, the SO2 of the patient is absolutely normal, right? So we want to decrease the CO2 for that patient. So if we decrease the respiratory rate of the patient, we are going to enhance the CO2. That means the first option goes out of the column, right? The first option goes out of the column. Pertaining to the option C, I told you that these figures happen in ARDS-like scenarios. These happen in ARDS-like scenarios where you tend to increase the PEEP of the ventilator. Now, to decrease out of these options, to decrease the CO2 levels, we have to increase the tidal volume, and in turn that will increase the gaseous exchange at the level of the alveoli, and that will tend to reduce the CO2 and further the requirement of FiO2. So in this question, the correct answer has to be increased tidal volume, decreased respiratory rate, increased PEEP to 14 is these options are not correct. Pertaining to this question, although the information given in this question is not at all complete for you to know all these things, but still I feel that if you have put some logic of capnography, and if you knew something about ARDS, that in ARDS there is a collapse of alveoli, we need to increase the pressure at those levels, then you would have come to this conclusion that we have to increase the tidal volume to reduce the PCO2 for this patient. So guys, from you people only, I have got these questions. Still, if you have any problems pertaining to anesthesia, I will still request you all to be stuck to your notes which we are giving. All the notes given by the Prepladder faculty by me are sufficient enough. There will be some stupid questions all the way in your examination every time you go and write this exam. But I again request you to have a firm grip on the points, on the notes which you have with you and the questions which are being asked frequently. Still, if you have any other problem, just message me or ping me on the Facebook page of Prepladder, where I have created the link. I'll try to solve as much as problems as you have. All the best for your results, and hoping to see you on the other side. Thank you, guys.
Okay, so good evening all, and happy to see you all back after the exam. I hope you all did the exam very well. And in this session, we'll be recalling the pharma questions asked in INI CET 2023, that is May session. And myself, Dr. Bharat Kumar, Pharmacology faculty. So before I begin, I just want to make sure that the audio video is fine. So before I begin, okay, so shall we proceed? Yeah. Yes. So before I begin, let me start with a disclaimer. The questions discussed in this PPT are recall based, and the motive of this session is to get the actual question asked in the exam. Yes, Amrita, the final question received after discussion will be uploaded in the Prepladder app. So that is our purpose. We'll try to discuss some of the important aspect. What was asked in pharmacology. Now, what is true about lithium? So, lithium is always a favorite for examiner. There is no question paper without lithium. So that's why the question has been repeated. So moving on to the options here, they have asked what is true about lithium. The first option is lithium is not teratogenic. Obviously, it's a false statement, and we all know that. Lithium is a teratogenic drug which can produce Epstein's anomaly. So the drug can produce a cardiovascular defect. So CVS defect, and the CVS defect name is Epstein's anomaly. It is not absorbed through gut. It's a false statement. Remember, lithium, we use it as lithium carbonate salt. So it has a very excellent absorption. Very good absorption. And specialty of pharmacokinetics is it is excreted without any metabolism. So it is excreted as such, that is lithium. So very good absorption when you give it through GIT, that is oral route, it has very good absorption. It has very good absorption. It is used for absence seizure treatment. No, lithium is not used for absence seizure treatment. If I tell about lithium, lithium is a drug which is used for the bipolar disorder. It is used for mania. It is even used for a patient having unipolar depression. Unipolar depression also, the drug is used. Now, one more important use of lithium is it is used in a headache called hypnic headache. The headache is called as hypnic headache. There also lithium is used. One more advantage of lithium is it has anti-suicidal property. Anti-suicidal property. Along with that, one more drug which has anti-suicidal property, the antipsychotic drug name is clozapine. So this is also false statement. Sir, what drugs are used for absence seizure? Two major drugs used for absence seizure. One is called ethosuximide and one more is called sodium valproate. They are the major drugs for absence seizure. It causes fine tremors at therapeutic dosage. This is the true statement. So fine tremors is the most common adverse effect what we see with lithium. Suppose if they give in the exam, patient is having coarse tremors. If the patient develops coarse tremor, then we suspect lithium toxicity. So normal dose, that is therapeutic dosage, you will see the fine tremor, and at high dose we will see the coarse tremors. So that is a catch here. So everything has been already asked in the exams. So lithium toxicity, do we have an antidote? No. Can we do dialysis in lithium toxicity? Yes, you can do dialysis in case of lithium toxicity. Because the reason is the drug has narrow therapeutic index. That is the reason. Moving on to the next question. A female patient with a diabetes. So patient has diabetes. They have not mentioned the age. She was given an oral drug which reduced her HbA1c, that is glycated hemoglobin, from 7.6 to 6.7. So it has reduced the HbA1c. The patient had high GIP, that is called glucose dependent insulinotropic polypeptide, and GLP-1 levels with low glucagon levels. Now, the drug given to the patient is. Now, it's a simple question, but remember, some of the words will only tell you the answers here. So, the drug is oral drug. So, liraglutide is not oral, pramlintide is not oral. Oclibose is a drug which is a alpha glucosidase inhibitor. It's a alpha glucosidase inhibitor. Correct? Now, what is this gliptin? This is called allogliptin. It's a DPP4 inhibitor. So, what happens when we give oral glucose? When the oral glucose reaches the gut, it releases something called incretins. So, these incretins are released from intestinal ulcers. So, incretins will have two important aspects. Incretins will have two important ones. One is called the GLP-1 and the GIP. So, we have this GLP-1 and GIP. Okay, Sukhbir Singh, I think the stream is fine. I'll just check with this. Just a minute, hold on. Okay, so sorry for the inconvenience, just stay connected. So oral glucose, we have incretins, that is GLP-1 and GIP. Now these incretins have a specialty. What do? These incretins will slow the gastric emptying. They will slow the gastric emptying. And not only that, they decrease the glucagon. And they stimulate appetite. And not only that, these also increase insulin release. So this is the role of incretins what we have. Now the nature will produce these incretins, but these are very, very short acting. So they are broken down by the enzyme DPP4. So this is the enzyme which breaks the incretins. So what the scientists did is they block this by using gliptins. For example, allogliptin, sitagliptin, linagliptin. When we inhibit this, these levels increases and they are beneficial in slowing the gastric emptying, decreasing the glucagon, decreasing the appetite, that is stimulating the satiety center. So they can stimulate the satiety center and they can increase the insulin release. So this is what the advantage of that. They stimulate something called satiety, that means feeling of fullness. So the liraglutide is what we mean by the GLP-1 agonist, and pramlintide is what we mean by the amylin, the receptor agonist. So here the answer will be allogliptin because it's a DP4 inhibitor. I'm not getting your messages, just a minute guys. Okay, I hope things are fine now. Yes, so the answer will be allogliptin, and when we give allogliptin, it can increase the GLP-1, GIP-1, as well as they slow gastric emptying, they decrease glucagon, they stimulate satiety and increase the insulin release. Let's move on to the next question. A female patient with vulvovaginal pruritus was on antidiabetic drug. Which drug can cause the above mentioned adverse effect? Obviously, it's a repeatedly asked question. Canagliflozin or any gliflozin, they are SGLT2 inhibitors. So they are sodium glucose transporter 2 inhibitors. So they lose glucose in the urine, glucose urea. So since they lose glucose as well as sodium, the disadvantage of losing glucose is the bacteria can multiply, so leading to urinary tract infections. And also the patient may develop the genital mycotic infection. Genital mycotic infection, that is the reason she is complaining like that. Right, so that is seen with SGLT2 inhibitors, gliflozins. Apart from that, rarely they can cause Fournier's gangrene, diabetic ketoacidosis, and also canagliflozin. Some people it has shown to increase the lower limb amputation, and gliflozins have shown to increase the risk of fractures. Repeatedly asked question for it. Now, metformin is not going to cause that problem. So, metformin mainly two important problems. It can decrease B12 and it can cause lactic acidosis. Linagliptin is a DP4 inhibitor. It is one of the safest in renal failure and no dose reduction renal failure. Liraglutide is a GLP-1 agonist and the drug is approved for management of obesity also, not only diabetes. One more GLP-1 agonist which is approved for diabetes as well as for obesity is called as semaglutide. The name is semaglutide. So the answer here is the drug canagliflozin. Yes, any other queries? Please ask me here. So a new drug, it's not a monoclonal antibody, a new drug is approved for Rett syndrome. I think psychiatry they have already discussed. So the name is called trofinetide. So the name is called trofinetide. Is a recently approved drug in 2023 for a rare genetic, neurological and developmental condition that is Rett syndrome. The name is called trofinetide. It's a tripeptide. Now moving on to the next question. Keynotes trial 189 is done for. Usually these type of trials you will know if in your colleges, if they are doing some journal club or seminars, then only you will know that. Now pembrolizumab and nivolumab, they are all called as immune checkpoint inhibitors. So keynote trial deals with usage of the drug pembrolizumab with chemotherapy for non-small cell lung cancer. So the usually pembrolizumab is given with another anti-cancer drug that is called pemetrexed plus platinum therapy. So along with platinum therapy, this is used. So this trial has been given a name that is called Keynote Trial 189. Sometimes this type of rare question we will get it, but unless you have attended some journal club or seminar, then only you can answer this. So that is about the answer, that is pembrolizumab with chemo given for non-small cell lung cancer. That is a keynote trial. So every trial they will have a name, and here they have given it as Keynote Trial 189. Moving on to the next question. A patient presented with dizziness, cool clammy skin, pinpoint pupil with blue lips and fingernails, suffering from respiratory depression. So patient had respiratory depression. The patient was producing pink frothy sputum and coughing. What is the drug used to reverse the effect? Now whenever they give this type of poisoning, check the pupil size. So if the pupil is myotic, we need to suspect two poisons. What are the two poisons we need to suspect? Number one is OP poisoning and one more is opioid. In OP poisoning, you have the typical adverse symptoms, that is dumbbells, diarrhea, urination, meiosis, emesis, bradycardia, bronchospasm, lacrimation, salivation. In opioid poisoning, you will have the mnemonic is CPR. C for patient may go for coma, the P for pinpoint pupil, and R for respiratory depression, and the 3H. So 3 hypo conditions, that is temperature will become low, hypothermia, hypotension, that is BP will come down, and one more important thing is hyporeflux. So these are the poisons where you see the meiotic pupil here. Now, where do you see mydriatic people? You will see in atropine poisoning as well as the sympathetic drug overdose, that is cocaine and amphetamine. So let us analyze the symptoms. Pinpoint pupil, blue lips. Why? Because opiate poisoning can cause cyanosis, and fingernails suffering from respiratory depression. I told you opiates can cause respiratory depression. And why pink frothis sputum? Sometimes opiates after some hours they can cause pulmonary edema, and that's the reason patient had pink frothis sputum on coughing. So here the overdose is opioid, and the best drug to reverse that is naloxone. Naloxone is a IV drug, so it is given intravenous. Why we cannot give orally? Because it has high first pass metabolism. It is used at a dose of 0.4 to 0.8 milligram, and it is repeated every 2 to 3 minutes. So how do we know the response of naloxone? The respiration should pick up. If the respiration is picking up, then naloxone is working, and if it is respiration picks up, then we can repeat naloxone after 1 hour or 4 hours. So atropine is the antidote for the OP poisoning as well as carbamide poisoning. Phentolamine, it is commonly used in the management of the cheese reaction and chloride withdrawal reaction and pheochromocytoma. And physostigmine is an antidote for atropine poisoning, also called as datura poisoning or belladonna poisoning. Yes. Okay, so it was a straightforward question, then no problem. If it is a straightforward question, the answer would be naloxone. So even if you are attempting for the future exam, you should be knowing how to analyze other options. That's why I'm discussing with you all. Right, so we will come to the conclusion. The answer is naloxone. Naloxone is not the antidote. It is used later. First we give naloxone because it's an IV drug. Moving on to the next question. A patient of schizophrenia is being treated with clozapine. For which rare but serious side effect should he be monitored? Now clozapine. Now clozapine is again a favorite for examiner. Clozapine. So whenever you think of clozapine, what is it? Clozapine is an atypical antipsychotic. It's an atypical antipsychotic, correct? Sir, what do you mean by atypical antipsychotic? It is a drug which blocks 5-HT2 more than D2. So what is the advantage, sir? Less extraepidermal symptom and less chance of hyperprolactinemia. But the problem with this clozapine and olanzapine is metabolic syndrome. They can produce one of the adverse effects that is called metabolic syndrome. Metabolic syndrome, that is weight gain, dyslipidemia, all those things. The drug can also produce agranulocytosis. Now, is this agranulocytosis seen? No, it's a rare problem. It is seen in less than 1% of patients. And it's a serious complication. That's the reason when we put the patient on clozapine, we should monitor the complete blood count. So when do you see this? It is seen within 6 months of starting clozapine, and the peak adverse effect is seen after 2 to 3 months of starting clozapine. You have to monitor for that. And that's the reason agranulocytosis is the answer for this question. Is there any other drug which is used in thyroid which can cause agranulocytosis? Yes, they are called as thioamides. For example, propyltyrosine, carbimazole, methimazole, they can also cause agranulocytosis, which is rare with them. One more anti-epileptic drug which can cause agranulocytosis is carbamazepine. That is also rare with that, but it is shown with that. So what about myocarditis? Myocarditis, we have certain reports. It is shown to produce myocarditis, but in some people only it is seen. And we not monitor for that. Seizures, sir. Now remember, seizures with clozapine will occur with high dose only. So if you increase the dose, seizure occurs, and that too it is seen in 1 to 3% of patients. Here you can see it is seen less than 1% of patients. That's the reason it is rare. Seizures occurs in 1 to 3% at high dose. So seizure is called as dose dependent. That means if you increase the dose, seizure also increases. Now agranulocytosis is called dose independent. Whatever dose you give, it is seen, but it is less, that is rare adverse effect what we see. So the answer will be agranulocytosis. Sir, apart from this, do we see any other adverse effect with clozapine? Yes. Again, this question appeared in your exam. It can cause cyalloria. Cyalloria. Now, clozapine has a specialty because not only it blocks 5-HT2, D2, it's an alpha blocker, muscarinic blocker, and histamine blocker. Now, since it's a muscarinic blocker, it is an anticholinergic property. So, obviously, when it has anticholinergic property, it should cause dry mouth, not cyalloria. But it's a paradox what we see with clozapine. So, clozapine produces a paradox that is called cyalloria. So, how do we manage that? We give local atropine. We give local atropine. What is the reason for cyalloria? Clozapine has M4 agonism in salivary gland. And all these things are additional point you have to keep your mind when you read about clozapine for your future exams. Right? So that is a beautiful drug, clozapine. And repeatedly the question is asked in the exams. Clear? Yes. So let us move on to the next question. Which of the following is true about clinical therapeutic index? Now, what is therapeutic index? It's an index which will tell whether the drug is safe to use. If it is narrow therapeutic index, it is less safe. For example, lithium, then the TCAs and digoxin. So therapeutic index is LD50 divided by ED50. Yes, that's the true statement. Now, how do I obtain this therapeutic index? Now, you know that if I give some dose to some person, he will respond differently. Some people, if I increase the dose, then only they will respond. So people will respond to the dose. That is, pharmacodynamic response differs from person to person. So if I want to plot that graph, what we use to plot that is called graded dose response curve. So we call it as graded dose response curve. No, is it called graded? No, it is called as quantal DRC. It is called as quantal DRC. Quantal DRC. Okay. Now, what is quantal DRC? Here in y-axis, we write the percentage of population. So we take the population into consideration. So here, 100% of population, 50% of population. Correct? So what we do is we increase the dose and see what is the effect. So we see the efficacy here. So this graph is called efficacy graph. Now, if I increase the dose further, the drug can also produce toxicity. So that is called toxicity graph. For example, for few people, if you give 4 grams of paracetamol, nothing will happen. For few people, if you give 4 grams, they will end up with hepatotoxicity. So this will give us 2 important parameters, that is effective dose 50, that is what is effective in 50% of population, and TD50, that is called toxic dose 50% of population. So from that, what we obtain is therapeutic index, which is given by TD50 divided by ED50. And in animal studies, instead of TD, toxic dose, we use something called LD50. Sir, what is LD50? LD50 refers to lethal dose. That means how much dose is required to kill 50% of animals. That is called LD50. Right. So please understand, here we write the percentage of population, here we write the logarithmic dose. So it's a calculation done in percentage of population, not in individual. It's not done in individual. So this gap is called as therapeutic window. This gap is called therapeutic window. If it is very narrow, the drug is less safe. It is very broad, it is more safe. So they can also ask you, therapeutic index is a measure of what? It's a measure of safety. That is what they can ask. Yes. So even if you are not sure about the option, this finds the right place. Dose in which efficacy and toxicity can be balanced in individual. See, we don't do this therapeutic index in an individual. I told you it is in population, so this is ruled out. Measures therapeutic index in a population versus individual. No, it's population only. Against the dose we calculate it. It is only used for specific individual. So if you are doing it in specific individual, then we call it as the graded dose response curve. Right? So what is therapeutic index? We do it in population, then we know. For example, most of them will get relief from the fever when we give paracetamol between 500 to 650. That is called ED50. If I increase the dose to 4 gram to 8 gram, patient may have hepatotoxicity. That is called a toxic dose 50. So that is very, very important when we use the drug. Yes. Okay. Okay, so whatever the option, this is what we need to understand. And this is what the factual basis for this. Okay. Let us move on to the next question. What is the treatment of HER2 positive trastuzumab resistant breast cancer? Now guys, this question is not new. I still remember when I was writing my entrance exam, this question appeared. So it's a repeatedly asked question. So trastuzumab is a monoclonal antibody against HER2/neu, which is an epidermal growth factor and which is responsible for breast cancer. So if the person is resistant to that, the next drug what we can use is lapatinib, and it's a tyrosine kinase inhibitor. One more drug similar to that is called neratinib. So these are used for breast cancer patients. Breast cancer. Sorafenib is also a tyrosine kinase inhibitor, but it blocks vascular endothelial growth factor receptor tyrosine kinase, and it is the drug which is used for hepatocellular cancer. Remember, SORA, solely for hepatocellular cancer, it's the only drug used in these cases. Apart from that, we use sorafenib in renal cell cancer, also in papillary carcinoma of thyroid. The next drug is called vemurafenib. The name itself is telling you RAF, so it is used in a RAF mutation. So it is called as VRAF, that is VRAF, that is a mutation in something called BRAF mutation. So whenever there is metastatic melanoma, then only we use the drug vemurafenib. So it is against the mutated BRAF, which is seen in metastatic melanoma. Erlotinib is a tyrosine kinase inhibitor for epidermal growth factor, and that is also used in non-small cell lung cancer. So most of these questions are framed by the faculties who mainly INI CET, they frame the drugs used in cancer therapy to make the paper tough, right? So don't worry about these type of questions, but this question is a repeated one. So it's not a new one. Please understand, it's a repeated question for you. Clear? Yes. Which nomogram scale is used for vancomycin dosage? Now, these are all clinical applications. If you see in the hospital, you will understand that. Particularly in the hospital like the national importance, like AIIMS, JIPMER, they follow these nomograms. Now, when we give vancomycin, we know that it's one of the wonderful drug for MRSA, but we know that it also causes nephrotoxicity. So if I want to give vancomycin, I have to take care that the drug is given at a proper dose. I cannot give overdose because patient may have nephrotoxicity. I cannot give underdose because if we give underdose, the drug follows something called time dependent killing. So you have to maintain the drug level above MIC every time. So we use nomogram scale, and a scale that is used called Matzke scale. Was this the question? Or did they ask you vancomycin used for which scale? So this is a scale through which we will understand how much vancomycin should be given. So what is nomogram? Nomogram is a parameter through which we give proper dose to the person. Depending on the pharmacokinetic parameters, age, weight, kidney parameters, depending on that, we give the dose of the drugs. So for example, I will show you a nomogram. Suppose I want to give vancomycin. Nomogram will take the consideration of body weight. See here, suppose the body weight is 40 to 49 kg, then the loading dose of vancomycin should be 1000 milligram. If it is 50 to 59 kg, it should be 1000 to 50 milligram. So if I want to maintain the dose, you know that maintenance dose depends on clearance, that is depending on kidney. So if you want to maintain, so here you can see the body weight 40 to 49 kg. If the patient is this much kg, even GFR is 31 to 40, then you have to give 750 milligram 24 hourly one. 41 to 60, you have to give 750 milligram 12th hourly. If the GFR is more than 60, then you have to give 750 milligram 8th hourly. So this is how it will help us, so that we will not give the drug low dose or we will not give the drug high dose causing toxicity. So this is the nomogram. And that is the future. Right? And obviously when we are entering the aims and all these things, the levels, what they will take up is this type of questions. Okay, so now one more scale which is used, there is one more option in the scale that is called Rumack-Matthew nomogram. Sir, what is this? Have you heard of this? Anybody? Rumack-Matthew nomogram. Have you heard of this? I'll just show you that. So this is the nomogram for paracetamol toxicity. What happens when we give paracetamol? Paracetamol can cause hepatotoxicity. So when the patient has taken overdose of paracetamol, I need to give an antidote, and that is called N-acetylcysteine. Sir, should I give N-acetylcysteine or not? How do I decide? I decide using this nomogram. Now this nomogram contains in y-axis the concentration of paracetamol that is represented in microgram per ml, and it is also the treatment should be given or not. So you can see in y-axis, in x-axis you can see hours after ingestion, and in y-axis the plasma concentration of acetaminophen. Now this, if it is 200, then after 4 hours injection, then we get a line that is called Rumack-Matthew line. So that was the beginning in the earlier days. Then the US FDA changed this line to the below line. So if the drug is below the line, this area, then there is no need of giving the N-acetylcysteine. If it is going above this line, then you have to start the antidote that is called N-acetylcysteine. So why these are important? Because if you don't start N-acetylcysteine early, patient may develop hepatotoxicity and patient has to be given liver, and getting a liver transplantation is not an easy job nowadays. So that is what the Rumack-Matthew nomogram will help us to predict the paracetamol and the toxicity levels. Okay, so these are the future questions what we can expect in the exams. Okay, a kid went to a temple with his grandmother and was constantly crying. So we don't know why it is crying. On examination, he had excruciating pain, hypotension, increased heart rate, sweating profusely, priapism, and cold, clammy skin. What should be treatment given to the patient? Now, looking into this, if I see the option, adrenaline, you know that adrenaline is given if the patient is having anaphylactic shock. So here there is no swelling of lip or rashes, nothing like that. Anti-snake venom, they have not given any cobra bite or any neurotoxic features, they have not given. So here what we are seeing is excruciating pain. So in India, we see the scorpion sting commonly. So what happens if scorpion stings? Now when the scorpion stings, it is going to activate autonomic nervous system. It will activate both sympathetic as well as parasympathetic. That's the reason you will see both hypotension and hypertension. You will see bradycardia as well as tachycardia. But the main problem what happens is the myocardial dysfunction occurs. The heart is not able to pump properly and patient may end up with pulmonary edema. And that's the reason for death. And in that cases, in India, what happens? The scorpion sting will activate more of sympathetic system. The activation of alpha predominates. So when alpha predominates and alpha action is predominated, the drug of choice for scorpion sting will be prazosin because it's an alpha blocker. Suppose the patient develops myocardial dysfunction. If the patient develops myocardial dysfunction, that means the heart is not able to pump properly and patient will develop pulmonary edema. In that case, I need to increase the myocardial function and the drug used is darbutamine. Along with that, we can also add vasodilators such as sodium nitroprusside. So these are used in the later stage if the patient is going for the cardiac complication. Otherwise, the beautiful drug prazosin, and remember prazosin is given as oral drug. Remember, it's not an IV drug. Prazosin is an oral drug. Please remember that. So the answer is question is scorpion sting. The answer is prazosin, repeated plenty of times. Clear? Yes. Okay, Sukhbir Singh, kit present to emergency in 3 hours also given. Okay, that is fine. So presented within 3 hours, very good. And you can see the hypertension, I told you, it can show both hypertension, tachycardia, bradycardia, sweating, priapism, all those things are seen. And it's a scorpion sting, excruciating pain. Sir, what we do for pain? Either we keep the ice packs or we give local lignocaine. That's what we can do. Yes. Now moving on to the next question, match the following. Now, even though we don't know the option, mirabegron, we all know that the beta 3 agonist. Mirabegron, we have a recent drug called vibegron. Beta 1 is present in the heart, so cardioselective beta blocker, which acts on the heart, is called bitoxolol. Then isoprelin, it acts on all the beta receptors, beta 1 and beta 2. So it's a beta 1 and beta 2 agonist. So we can take this into this consideration. Right? So these are the options what we have. I hope these are the options. Did I add anything else? Sukhbir, Min, PPP. Was there any other extra drug given? Please tell me. Okay, so let us assume that this was the question. What is the mechanism of thalidomide? Now, thalidomide, if the first thing that enters your mind is it's a teratogenic drug and it was stopped. Why it was used? Because it has anti-emetic property, it had sedative property, anxiolytic property. But later, thalidomide was shown to produce anti-inflammatory property. It had anti-inflammatory property and it had anti-angiogenic property. So this anti-angiogenic property is very, very important in treating cancers. So the mechanism of the drug is angiogenesis inhibitor. It will not inhibit leukotrienes. It will not prevent folic acid synthesis in bacteria. It will not inhibit factor Xa. So the drug is thalidomide. Thalidomide as an anti-inflammatory drug, it is used in a condition called erythema nodosum leprosum. If it is a recurrent ENL, thalidomide is a drug of choice. Apart from that, it is also used in Behçet's disease, that is oral ulcers, and also it is used in a condition called multiple myeloma. So the drug thalidomide is used. What is the adverse effect of thalidomide? It is teratogenic, so it can produce phocomelia. Okay, was not a mechanism of action in its teratogenic effect. So what were the options? Anybody? Phocomelia, that is a teratogenic effect. Drug can produce sedation. The drug can produce constipation. And the drug can produce sensory neuropathy. So these are the adverse effects what we see with thalidomide. Right? So this is the question, and any other options you can message me here. Now moving on to the next question, 35-year-old male patient present to surgery emergency with a painful erection for past 7 hours. So painful penile erection is called priapism. He has a history of mood disorder and was recently prescribed a medication by treating psychiatrist. What is the offending drug? It's an obvious one. The answer is trazodone. Trazodone belongs to atypical antidepressant. It's a 5-HT2 blocker. And also it is an alpha blocker. So since it's an alpha blocker, it can cause vasodilation, and the vasodilation is responsible for penile erection, that is priapism. And vasodilation is also responsible for postural hypotension seen with trazodone. Now similar to trazodone, we have a drug called nefazodone. Nefazodone is withdrawn in some of the countries because the main problem with the drug is hepatotoxicity. The mechanism is similar to trazodone. It's also 5-HT2 blocker and alpha blocker. Mirtazapine is called as NASA, noradrenergic and specific serotonergic antagonist. It is one of the drug which is preferred if a patient has depression and insomnia. So that's a best drug for a patient who has depression and insomnia. One more counterpart of that is miancerin. Venlafaxine belongs to SNRI. Tianeptine and one more counterpart of that is called amineptine. They both have shown to increase the serotonin uptake. Usually, antidepressant inhibit the serotonin uptake, but here these two drugs increase the uptake. That is tianeptine and amineptine. So here the answer will be trazodone. Clear? Yes. Okay, guys. So that's it from my side, and hope your exams went well. I know pharmacology you had some new concept, but whatever new is always new for everyone. So don't worry about that. Whatever is being repeated, you shouldn't have done the mistake. So that is my message to you, because if we want to set a 200 marks paper, obviously we need to give some question stuff. And the questions which are already asked and repeated, that question should not be made a mistake. So now you have finished the exam, try to relax, then wait for the results, and dedicate your energy in other things. I know you are into this books from so many days, so watch some movies, some books you can read, you can go out, wander outside, relax. Then all the best for your results. All the best for your result. Okay, Min, thank you for that message, and that makes my day. Thank you all. And so don't worry about the questions. It is like that only. Last year, INI CET Pharma questions were like repeated easy one. But this time, every year, if the INI CET, there is some question related to cancer, that are newer drugs, there will be there. Okay. Okay, and standard question only. Lithium was standard, clozapine was standard, therapeutic index is standard. So questions which came were standard, except that trial, keynote trial. Undergraduates usually cannot answer those questions, and the nomogram. So those were the concept. Yes, anything else you want to ask me? Okay, guys, if there are no queries, and we'll be pausing the stream now, and the next faculty will take over. All the best for your upcoming exam, upcoming results, and hope to see you with flying colors. My best wishes to you all. Thank you, take care, and any queries you can put it in the comment box, and we'll be happy to answer this. Thank you all.
Hello friends, a very good evening to all of you. So please confirm if my screen is visible and if I am audible. Waiting for your reply. Yes? Am I visible and audible? Can someone please message in the chat box so that we can start? Please confirm if I'm audible and my screen is visible. Okay, thank you, Narayana. Okay, So, welcome to this, session, recall session of pediatrics, and we'll be discussing the around 10, 12, 13 questions which I could gather from pediatrics from this INI CET May 2023 exam. So, you all must be feeling really relaxed now with your exams being over. And so we'll just keep this discussion very brief one. So we'll just be discussing about what questions came, and we should, irrespective of whether we are able to clear this exam or not, we should, the learning is a continuous process and it should never stop. So we'll just quickly go through these questions and we'll try to make the most of the next 20 minutes or so. Okay, so let us move ahead. So as I mentioned, the purpose of this session is learning, and we are trying to recall the questions so that it is beneficial for your juniors the next time. And I hope all of you are able to fare your level best in these exams and you are going to clear it through. Okay, so moving straight ahead. So the first question that we are going to discuss: a child who presented with the following appearance can present with. So we've discussed it in our image based questions also. So you can see that what you have, the rash which is there on the cheeks of this child. So this is the typical slapped cheek appearance of the rash, as if someone has slapped on the cheek of this child, right? And this is typical of a parvovirus infection. So in other words, this question is trying to ask us that a child who presented with the following appearance can present with. So a child with parvovirus infection, in other words, can present with which of the following? So is it pure red cell aplasia? Is it immunodeficiency, lymphoproliferative disorder, or gingivostomatitis? So pretty straightforward question, we all know. So parvovirus causes this erythema infectiosum, which causes this slapped cheek appearance of the rash. So this is erythema infectiosum, which has the slapped cheek appearance of rash, and we know it is caused by parvovirus, right? And amongst the given options, what can parvovirus cause? So parvovirus can cause this pure red cell aplasia, right? So I'm sure all of you have done it correctly. So a pretty straightforward question that came. So moving ahead to the next question. So which of the following is least likely to be transmitted perinatally? So we know, perinatal transmission is mostly there. Typically, we say for the TORCH group of infections, right? So which would include, toxoplasma, some other infections, rubella, CMV, herpes, syphilis also. And amongst the hepatitis, the ones which are transmitted perinatally are mainly the hepatitis B and C, okay? But hepatitis A, on the other hand, has got fecal-oral transmission. It is not one of the viruses which is typically transmitted perinatally, right? But we know HSV can be transmitted perinatally, rubella can very well be transmitted perinatally, and CMV also, right? So very good, Narayana. So which of the following is least likely to be transmitted perinatally? So our correct answer, we are left with hepatitis A, right? Again, a pretty straightforward one. This again is a cakewalk, enzyme deficient in Pompe's disease. So we all know Pompe disease is a glycogen storage disease. It is one of the muscle glycogenosis where mainly the muscle is involved. And Pompe disease, is we know, is due to the deficiency of acid maltase, okay? Or it is also called alpha-1,4-glucosidase. Alpha-1,4-glucosidase. So in Pompe's disease, typically we all know a child will present as a floppy infant. Okay, floppy infant will be there. So there will be skeletal muscle weakness. There is cardiac involvement also. So you can get cardiomegaly, and you can get, hypertrophic cardiomyopathy can be there. ECG changes can be there. So I'm sure you all have made this correct. So this is acid maltase. So we know glucose 6-phosphatase deficiency is seen in von Guericke disease, right? Muscle phosphorylase is deficient in McArdle disease, which is another type of muscle glycogenosis. Phosphofructokinase deficiency is seen in Tarui disease. So these are not the correct answers. So we are left with acid maltase or alpha-1,4-glucosidase, which is deficient in Pompe disease. And Pompe disease, friends, is also important because, enzyme replacement therapy, which is the specific treatment, is now very much available for this disorder, right? So moving ahead, again a very, very important topic which has been asked multiple times and which we've discussed multiple times in our, marathon sessions, in our image-based sessions. So a child with fever for 6 days. So there is fever for 6 days. Strawberry tongue. So you can see this strawberry tongue, okay? The appearance of the tongue, which is red, congested, looks like strawberry, right? Conjunctival congestion, which you can see. So non-purulent conjunctivitis. You can see the strawberry tongue here and you can see the conjunctival congestion, bilateral non-purulent conjunctivitis, along with peeling of skin. Okay, what will be the treatment of choice for this child? So again, friends, I'm sure all of you, very good, Dihana. So we all agree that the diagnosis here is Kawasaki disease. We all know the diagnostic criteria. N number of times we've discussed. Yeah, right. So it is fever for more than 5 days with any 4 out of the 5 cream features. So cream is C for conjunctivitis, R for rash, E for edema and erythema of extremities, A for adenopathy, and M for mucosal involvement in the form of strawberry tongue. Now, friends, again, we've already discussed what is the treatment of choice for Kawasaki disease. So I'm sure you all have made it correct again. So what is the treatment of choice for Kawasaki disease? Very good, Mir Suhail. It is IVIG. So intravenous immunoglobulin is the treatment of choice for Kawasaki disease. Even though, aspirin is also used in the treatment of Kawasaki disease. Remember, just like rheumatic fever, aspirin is used in Kawasaki disease also. Initially, high dose is used, followed by low dose. So aspirin is also used. Low molecular weight heparin is usually not required unless, there is an established thrombosis or something, and warfarin again is not indicated. So if, this question was a multiple answer type question, then I would have gone with the option which gave both IVIG and aspirin. Okay, so IVIG plus aspirin is the best option. So if it was a multiple answer type, go for IVIG plus aspirin. If it was a single answer type, then the single best answer would be IVIG. Because, if a child is given aspirin alone, then still there is a risk of cardiac complications in almost 20 to 25% cases. But if we give IVIG along with aspirin, then the risk of complications is very less than 5% of cases, right? So if one answer to be selected, go for IVIG. If multiple answer type question is there, then our answer will be IVIG plus aspirin. High dose followed by low dose, right? Okay. Now, causes of non-immune hydrops fetalis are all of the following except. So again, we all know what do you mean by hydrops fetalis. So hydrops fetalis is when there is collection of fluid in 2 or more areas in the baby's, in the fetus, right? So if there is generalized swelling, that is anasarca, along with either, peritoneal cavity fluid collection, okay, or there is collection in the pleural cavity or collection of fluid in the pericardial cavity. So any 2 or more areas are involved, then we call it hydrops fetalis, right? And hydrops fetalis we know can be due to 2 main group of causes. It can be immune hydrops fetalis, okay, and it can be non-immune, right? So immune hydrops fetalis can be caused either by Rh incompatibility or ABO incompatibility, right? Any of these, if they are responsible, then it is immune cause of hydrops fetalis. And rest, all the causes are going to be non-immune. So there's a long list of non-immune causes like, you can remember A, B, C, D, E, F, G, H, I, J, K. So almost any system involvement can be there. So A for anemia, so alpha thalassemia can cause it. Bone diseases like osteogenesis imperfecta can cause it. CNS features like, encephalocele can cause it. Cardiac anomalies, anything causing congestive heart failure or HLHS, endocardial cushion defect, heart blocks, diseases of lymphatic system, inborn errors of metabolism, even twin transfusion syndrome, chromosomal disorders like Edward-Patau, Downs, right? Hepatic causes, infections, infant of diabetic mother, kidney. So you can see n number of causes of non-immune hydrops. So remember, friends, here it is so easy that you can just pick out. So ABO incompatibility would be causing immune hydrops. So all the other causes would be non-immune hydrops. So congestive cardiac failure, parvovirus infection, chromosomal anomalies, all these are causes of non-immune hydrops fetalis. But ABO incompatibility or if Rh incompatibility would have been there, then they are causes of immune hydrops fetalis. So that is the answer, right? Moving ahead to the next question. So what we have here again is a 10-week-old, so pretty simple question, a 10-week-old child who comes for vaccination with previous history of inconsolable cry and fever after getting vaccinated at 6 weeks. What should be done next? So friends, we all know what are the vaccines that we give at 6 weeks. So at 6 weeks, we give the pentavalent vaccine, right? We give the first dose of pentavaccine, right? We give the first dose of OPV, first dose of rotavirus vaccine, right? We give the first dose of fractional IPV, and we also give the first dose of pneumococcal conjugate vaccine, right? So many vaccines are given at 6 weeks age. Now, out of these vaccines, the one responsible for this inconsolable cry and fever is mainly the DPT vaccine, which is a component of the pentavalent vaccine, right? So remember this DPT vaccine, especially the pertussis component of the DPT vaccine, the whole cell DPT vaccine, which is a part of the national immunization schedule, that can cause adverse effects like, persistent inconsolable cry or screaming episodes for more than 3 hours. It can cause hypotensive, hyporesponsive episodes, right? It can cause high grade fever. Sometimes seizures and all also can be there. So remember, this inconsolable cry and fever is not a contraindication for DPT vaccination. It is not a contraindication. The only two contraindications for DPT or pentavalent vaccines are history of anaphylaxis to a previous dose of vaccine, or if a child has a progressive neurological illness, right? So inconsolable cry and fever is not a contraindication for further doses of DPT vaccine. So give DPT vaccine is the best answer out of the given options. So very good, Dhyana. Give DT, no. We will give the pertussis component also. Don't give DPT again is not the correct answer. And defer for 1 month again will not serve our purpose. Okay, so deferring is not going to serve our purpose. So we will go ahead with DPT vaccination, right? Okay. So moving ahead, another question on vaccination that was there, which we have discussed in our immunization special circumstances. So all of the following are contraindications for vaccination except, okay. So we know that so all the disorders which are given in the options are, some forms of immunodeficiency. So in severe immunodeficiencies, we know live vaccines are contraindicated, okay. So we all know that. So DiGeorge syndrome, Wiskott-Aldrich syndrome, ataxia telangiectasia, all these three fall in the category of T cell and combined immunodeficiency, okay. And they are pretty severe disorders. So T cell and combined immunodeficiency disorders. So in these disorders, live vaccines are going to be contraindicated. So live vaccines are contraindicated. But in the category of complement deficiency, the vaccines are not contraindicated. You can continue the normal immunization schedule, right? So that is the best answer out of the given options. So complement deficiency, okay. Now, there was this another question on NADA's minor criteria for congenital heart diseases. So let us first see what is this NADA's criteria. So NADA's criteria is for the assessment of presence of congenital heart disease, okay. So it will not tell you whether the congenital heart disease is severe or not, or what kind of disease it is. It will just tell you whether a congenital heart disease is present or not, okay. So you have major criteria in NADA's criteria. What are the major criteria? Any diastolic murmur, okay, any diastolic murmur, systolic murmur more than, greater than, equal to grade 3, then it is a major criteria. Cyanosis or presence of congenital heart failure. So these are the major criteria. But the question is about the minor criteria in NADA's criteria. So what are the minor criteria in NADA's criteria? So systolic murmur less than grade 3, abnormal second heart sound, abnormal blood pressure, abnormal chest x-ray, abnormal ECG. So there are, one is the systolic murmur less than grade 3. Then there are two clinical things, abnormal second heart sound, abnormal BP, and two investigation related things, abnormal chest x-ray, abnormal ECG. Now coming back to our question. So NADA's minor criteria for congenital heart disease are, so diastolic murmur we know is a major criteria. It is not a minor criteria. Low blood pressure. So this is abnormal blood pressure. Yes, it is a minor criteria. Systolic murmur less than grade 3 again is a minor criteria. And abnormal second heart sound is also a minor criteria. So our best answer will be the option which has got the choices 2, 3 and 4, right? So friends, this was also this multiple answer type question. So this time, a lot of multiple answer type questions were there in your INI CET exam. So making the questions really more time consuming, okay, and more difficult to answer, right? Okay. So moving ahead. So there was this question on pedigree. Please confirm if this was the pedigree that was given. So identify the inheritance pattern in the pedigree chart given. So this pedigree shows that in each generation, so in generation 2 if we see, these two individuals are affected and one of the parents is also affected. Then if we see in generation 3, so this individual is, these two individuals are affected and the parent is also affected. Again, this individual is affected and the parent is also affected. So one of the parents is always affected. So this is a dominant disorder, okay. And we know father to son transmission. Can you see a father to son transmission here? So here see, this father is transmitting the disease to this son. So this rules out X-linked inheritance. We have discussed very clearly, this rules out X-linked inheritance. So it is autosomal dominant inheritance, okay. So this is a autosomal dominant inheritance, right? So very good. Again, Dhyana and Amruta. So autosomal dominant inheritance. It is not pseudodominant, autosomal recessive or X-linked recessive. Now quick word about what is pseudodominance. So I'll just touch this pseudodominance. So pseudodominance is seen in autosomal recessive disorders. What happens here? So in pseudodominance, so if an individual is homozygous, okay, for a particular trait. So if an individual affected with an autosomal recessive disorder is homozygous, say this RR, this is homozygous for this trait. So this parent is affected and the other parent is also a carrier. So this parent also has one abnormal, allele, and this parent has got two abnormal alleles. Then what will happen? 50% of their children will be affected. So you will have this capital R, small r, small r, small r, and you will have capital R, small r, and then small r, small r. So you will have 50% of the children will be affected. So it will appear as if it is an autosomal dominant disorder because this child is affected, this parent is affected. But this is not an autosomal dominant disorder. Here it is a recessive disorder, but because the other partner is also carrier, it is appearing as if it is an autosomal dominant disorder. So that is called pseudodominance. So why we are not considering pseudodominance in the example here? Because it may happen in one generation that suppose this father is the carrier and this is affected. So these two are affected. But again in next generation also we are getting that this parent is affected and these two are affected. So in every generation the other spouse is a carrier. That is too far-fetched to imagine, right? So autosomal dominant is the correct answer here and not pseudodominance, right? Okay. Now this was a pretty straightforward question. I'm sure all of you have done it correctly, right? Yes? So we all know trisomy 13. What is trisomy 13? So trisomy 13 we know is Patau syndrome. What is trisomy 18? We all know it is E for E. So 18 is for Edward. Trinucleotide repeat disorder, we all know Huntington disease is a trinucleotide repeat disorder, and hemoglobin point mutation of glutamate to valine in the 6th position will cause sickle cell disease. So this match the following question, pretty simple. So we have with A you have 2, with B you have 4. So with A 2 and B 4. So the first answer is the correct one. Very good, Vijay, Dhyana, Narayana, very good. So good to see that even after your exam you still have the enthu to answer it. I'm really proud of you guys. I'm sure you're going to do very, very well. Okay, and keep that spirit on, right? So I know it is the time to relax. Just, go through the questions once and just, and then you can just keep it in your memory, intermediate term memory, and take some time to relax and unwind and enjoy, right? So a couple of more questions to go. A young infant of 2 months age. So you have a young infant of 2 months age who was brought with multiple episodes of watery diarrhea and altered sensorium. Which of the following are possible based on the above findings? I'll need someone to confirm if this was the question or some other details were also there in this question. Please confirm. So what we have here is a 2-month-old child with multiple episodes of watery diarrhea, and there is altered sensorium also. So what all can give rise to altered sensorium in a child with diarrhea? Can severe dehydration cause it? Yes, we know in severe dehydration the child is going to be totally lethargic, right? So that is a part of altered sensorium. Can hemolytic uremic syndrome cause it? Yes, we know hemolytic uremic syndrome can cause altered sensorium, not really much, because TTP also you have neurological manifestations, not much in HUS. Rather, we would have suspected HUS if child had some bleeding manifestations because of thrombocytopenia, or the child had severe anemia, or if the child had anuria or oliguria, so evidence of renal dysfunction. So all these are not mentioned in this case scenario. So we are not thinking of HUS at this point. So hemolytic uremic syndrome we all know is a triad of microangiopathic hemolytic anemia, thrombocytopenia, and renal dysfunction. But here in this case scenario, we are not getting any evidence of bleeding. We are not getting any evidence of renal dysfunction or decreased urine output. So we are not considering HUS at this point, right? Hyponatremia is a possibility. So a lot of diarrhea and the child can land up in hyponatremia, and hyponatremia can cause altered sensorium and even seizures. Cerebral vein thrombosis is again a very important possibility. So in children with diarrhea and dehydration, what happens? The viscosity of blood increases. So there can be, sludging or, the slowing of circulation in the cerebral venous sinuses, and that can lead to thrombosis and a hypercoagulable state. These babies can present with altered sensorium, with seizures, with features of raised intracranial tension, right? So all these three remain a possibility in this situation. So our correct answer should have 1, 3 and 4. So we'll choose the option C, which has the options 1, 3 and 4. So I would want you to confirm whether, this was the question and whether these were the options, right? So please confirm if this was the question and these were the options, right? So I'm sure you are, you remember this question. So if there is altered sensorium, we can think of severe dehydration leading to it, hyponatremia leading to it, and cerebral venous thrombosis. HUS we will suspect in a different scenario, not this one, right? As we already discussed. Okay. So 1 and 3 was option you are telling. So severe dehydration and hyponatremia was there. Cerebral vein thrombosis, was it there as an option, or cerebral sinus thrombosis also people often call it? So where HUS and cerebral sinus thrombosis also the options. So please, if anyone else would also confirm, right? So moving ahead, I believe this is our last question for this evening. So in pediatrics, of course, you have Ruchi Rai ma'am waiting with the ophthalmology recall questions right after this. So what we have here is, a 6-year-old boy who was brought with chronic cough and foul smelling stools. So there is some respiratory involvement, which is, continuing for a long time, and like really it is kind of persisting, and foul smelling stools are there. There is history of a sibling who died of similar complaints in the past. So this is a disorder which has some inheritance and a genetic basis, it seems, and it is involving the respiratory system and the GI system, right? The child was found to have pathogenic CFTR mutations. So we all know the CFTR mutations are seen in which disorder? Again, we've discussed in our marathon and revision sessions. So cystic fibrosis, you will get pathogenic CFTR mutations. So which of the following ion is checked in sweat in this condition? So we all know we check for the sweat chloride, right? So sweat chloride, if it is more than 60 milliequivalent per liter on 2 separate occasions, then we diagnose it as cystic fibrosis. So of course there is the diagnostic criteria, which again we have discussed. So the diagnosis of cystic fibrosis, we will suspect if there are presence of typical clinical features like we had in this case, a history of cystic fibrosis in a sibling like we also had in this case. Positive newborn screening test can be there in the form of immunoreactive trypsinogen. So immunoreactive trypsinogen is used for screening for cystic fibrosis, right? 2 elevated sweat chloride concentrations more than 60 milliequivalent per liter. Okay, so that is the question which is being asked here. And identification of 2 CF causing mutations in the CFTR, which we already have here. Apart from that, nasal potential difference measurement can also be done. So this, friends, is a case of cystic fibrosis. Recently, in one of the recent exams, you had the question on mutation in cystic fibrosis, also the delta F508 mutation. So we know this is a very important topic and we have revised it frequently. So friends, these were the questions that I could, get from you students from pediatrics based on the recall of this exam. So I would request you, if there are any other questions which I have missed, so if you can share if any other questions which were there from pediatrics which I have missed, or some difference in the wordings or options of any of the questions, then it will be a great help for the ones who are appearing for the next NEET PG exam in the upcoming year. So there was no option which just excluded HUS, Roshan says. So Roshan, HUS was there in the option or was it not there? So we'll go back to that question. So was HUS there in the options or it was not there? So if anyone can give more clarity on this question, and if there were any other questions from pediatrics which we've missed, please mention in the chat box. So we'll be happy to include it there when we come up with a refined set of questions based on what the inputs that you give it to us. So it will be helpful for all of you. So, okay, salty kiss was there. Okay. So salty kiss again would go in favor of cystic fibrosis. There is increased sweat chloride. So sodium chloride increases in sweat. So these patients, the parents often complain of salty kiss in these babies. So that is an additional clue to cystic fibrosis. So thank you, Chandrasekhar. So good to know that pediatrics was easy with the lectures that we had. Okay. So it is, a pleasure and a privilege to know that you guys are getting benefited from what all we are discussing. So it's always very motivating and, very, very good to know, right? So if there are no other questions from pediatrics, so there was no option which had A, C and D, Roshan says. So Roshan, if you can pen down what exactly was the question and what were the options, so that will be really helpful in refining the questions. So if you recollect any other questions, you can write in the chat box below, or you can email the questions to me. So this is my email ID, dr.meenakshi.pediatrician@gmail.com, or you can message me on the Telegram or Insta or Facebook handles, or on the Prepladder handles, right? So please share if there are any other questions from pediatrics that we have missed. We'll be happy to discuss them, right? And we'll come out with a refined version based on all your inputs. So now, friends, this is the time to relax. So there's one more quick session by Ruchi Rai ma'am, and it is definitely the time to unwind and relax. So that's why we are keeping these sessions very, very brief. So please enjoy this time. Definitely this time is not going to come again. So do not harp on whatever has happened. You've put in your level best, okay? And it is time to be satisfied with it. And you will definitely get what is destined for you. So whatever will happen for the good. Just trust in the higher power, and it is the time to be contented and relaxed, and all the very best for your results. So I'll be waiting to hear from you. So friends, all the very best. Take care. God bless you. Thank you.
Good evening, all of you. So let's start. Good evening. So we are going to start with ophthalmology recall questions. So I think by now you all must be quite saturated. So many recall questions being discussed. So before I start, let me just tell this very clearly that we are going to have a very short discussion. I'm not here to talk too much in detail about the topics. You all are already saturated. We'll just have a quick idea what should be the answer and what are the questions. And I am just listening since yesterday that, okay, ophthalmology was difficult. Let's see, was it really difficult? Let's try to see this, right? Chandra, let us discuss ophthalmology was difficult or not, because when I was looking at the questions, I felt that the majority was simple. Let's see, one by one we'll discuss that, right? Yeah. So, okay, so this disclaimer is absolutely very, very important for you all to be very clear. These are all recall questions. Okay, we start with the question number 1. This was the simple one, Chandra? Yeah, Vijay, good evening. Good evening, all of you. So, this was a very simple question that this is what I got. The question is saying that the given image shows blanching of the vascularity after phenylephrine use. What is the likely diagnosis? Now, first of all, what is very, very important to understand is this is not a complete question. If you remember your phenylephrine test, so this has all been discussed in the app, in my lectures, you can go through that. So in the phenylephrine test, what do? See, this is a very, very favorite topic to discuss, that the same nodule can look like a flectin, like flectanular conjunctivitis. It can look like episcleritis, it can look like a scleritis. How to differentiate? The presentations are overlapping. And of course, interesting part is treatment is also almost the same. We start giving it steroids and all. Okay? So, how to differentiate? First, we start with 1% phenylephrine. If that 1% of phenylephrine, say there is blanching, it is a nodular flectin. Okay? So, this you should be clear that when we give 1% phenylephrine, right? And इसमें अगर blanching होती है, if there is a blanching here, we are talking about flectanular conjunctivitis. Now, if it does not blanch, now you increase it to 10% phenylephrine. Now, if it blanches, phenylephrine, right? And now, if there is a blanching, this means that it is the superficial episcleral plexus which is congested, and hence it is episcleritis. So then it becomes a nodular. Of course, why we say nodular? Because it's this nodule only which is causing a confusion. So it's a nodular episcleritis. And in spite of this, if after giving 10%, if there is a blanching, we are saying it is episcleritis, and in 10% phenylephrine also there is no blanching. Now we will say this is your scleritis, right? So now it becomes a scleritis, because in scleritis it is the deep episcleral plexus which is involved. Deeper vessels are involved, and because there are deeper vessels which are involved, therefore naturally there will be no blanching in with 10% phenylephrine. So what should be the answer of this question? What is likely vascularity after the given shows blanching? So it is showing blanching here. Now because see, if they have told you the percent, did it mention the percentage? How much percent? Okay, Anu, the percent was not given. So if the percentage was not given, then for the safe side, I would just answer episcleritis. I know it is not fair though. It is absolutely not fair to give a question so confusing like this. The percentage should have been mentioned. But if it is not, then looking at the clinical picture, okay, it is blanching or not blanching, we would answer this. And if it did not blanch at all, then there was no confusion of percentage, then it could have been scleritis. So how the question was asked, you all are better judged to understand what was the question. So if this was the exact question, this is not a very, very impressive question, because percentage should have been given. But anyway, still our best option becomes episcleritis. Okay? Okay. Or if the question was other way, because I am finding this version also from some students, that okay, the question was there was no blanching, then it is a clear-cut answer that it has to be scleritis, right? Then if there was no blanching, then it is a scleritis and there is no confusion also. So kya tha question mein? Can you all tell me? Was it blanching or not blanching? Anu, Chanda? So what was the question? Was it saying it was blanching, or this was the exact question which I am reading in front of you? Okay, so I'll wait for this to revert. Let me go to the next, meantime, to the next question. क्या पूछा था? दूसरा क्या सवाल आया था? We are talking about this. Which of the following lens is used in direct gonioscope? Now see, this is one question. If you all understand, that's why when I'm teaching, I keep telling you every one-liner, every Q, every double Q is important. In ophthalmology, you can't say that, okay, all only clinical scenarios are going to come. See, this was one where you had to actually mug up which are the direct lenses, which are the indirect. And I hope you have this concept of what are direct. And I think there were multiple options if I'm not wrong, right? So can you tell me which were the direct gonioscopes here? So Goldman is indirect, it is Cope and Richardson which are direct. So when you say direct and when you say indirect, see again this is all discussed in your Prepladder app lectures. So when you say direct, it means that you are looking at a direct view of the angle. Indirect means you are looking through this mirror is there and it is from the reflection from the mirror and then you are looking at it, right? So that means when it is reflected from the mirror, and indirect, when I'm looking superiorly, actually it is the inferior angle. When I'm looking inferiorly, it is the superior angle and so on. Okay? So natural, and I need the patient to be supine. Direct ones are mainly, I need the patient to be erect, not supine. I mean to say sitting position. When you say indirect, direct is mainly for surgical procedures, right? Or any surgical procedure in the angle, goniotomy, generally done through whatever you are doing, you through the gonio lens, it has to be, especially the goniotomy when you are doing the small child, it has to be the direct, right? So this is so simple. I don't think there is any confusion between direct and indirect. Reflected from the mirror is indirect. Indirect means you should be sitting. All surgical procedures done through direct. Okay? Investigations done through indirect. Achha, do you all remember the concept of gonioscopy? I think this is very, very simple, that normally what happens, that the light here is internally reflected in the angle. I'm showing it here only. So when it is internally reflected, why? Because you have to remember that physics, that the light passing from denser media to the lighter media, right? So if it is more than the critical angle, it will cause total internal reflection. What you do is, you change the refractive index of this media by putting a gonio lens. So if air was refractive index 1, you have put a gonio lens, this becomes the denser medium now, and therefore there is no total internal reflection. I think now it's very, very simple and clear. This is how we are able to visualize the angle structures. Chalo, अब हमें याद क्या करना है? Direct कौन से हैं? Please, you have to remember these names. A lesson learned from this exam. So, Copes, Richardson, Barkans, Wurst and Swan-Jacob. These are all direct gonio lenses. Can we note it down if you want to? And if you're too bored, okay, you can note it down later, right? Okay, Chandar, agar blanching not mentioned to nahi hoga, there must be something. It is blanched or not blanched. If it is saying, okay, so then you all send me the correct question. You can just put on Insta or DM me. Keep discuss directly there only. There. Okay, if there is still any confusion with that question. But I think you got the concept behind it, right? How we differentiate these three clinical conditions. Chalo, I am talking about the gonio lenses. So Richardson, Copes, Barkans, Wurst and Swan-Jacob are direct. Indirect mein, these are common names we know about: Goldman, Sussman, Posner and Zhang. Okay? So you have to, if you don't have to mug up, you just read 3-4 times, you will know it. Okay? Okay. So this was about your indirect lenses, and now then we talk about next question. Okay, so this was identify the mark, and we all know we have been discussing the condition. I think it was somewhere it should be here where they had asked you that what is the space. This is the only question which is causing so much of panic for ophthalmology. Huh? So this is the question definitely. I was just smiling at myself because I was trying to add it in the lections and I realized, okay, ये तो PG level का है, and why should we discuss so much? I don't want to burden my students. And now I see the same thing here. So anyway, it doesn't matter. Very, very simple thing. What you have to understand कि ये जो हमारे zonules हैं which are attached to the ciliary process, it is in form of a fork. See, this is a zonular fork. Okay. So if this is the iris, this becomes the anterior zonular limb. This becomes the posterior zonular limb. And this is the equator के ऊपर equatorial zonular limb. Is there any confusion? This is the lens. ठीक है? This is your iris. ये anterior हो गया, ये cornea है, right? So this becomes your anterior zonular limb. Then this is the fork, fork shape. Can you see the fork shape? This is the equatorial, this is the posterior. This whole thing is called zonular fork. This is how it is attached to the lens, first of all. Up the space between the anterior and the equatorial, this is what is called space of Hanover. ठीक है? Canal of Hanover. Anteriorly. And when you come to the posterior part, so this time this time just be very clear, this is the iris in this figure. So we are talking, this is anterior, pre-equatorial zone, right? And between the equator. So this is what is your canal of Hanover. किसके किसके बीच हो गया? Look at this diagram. किसके किसके बीच? Between the anterior limb and the equatorial. Now talking about the posterior, it is the posterior anterior hyaloid membrane of the vitreous. वहाँ पे जो zonule attached है, that is called, I am giving you one extra point here, that it is hyaloid zonules. Space between this hyaloid zonule and post-equatorial zonule is what is canal of Petit. So this is what they had asked you, what is canal of Petit. ठीक है? Any problem? अच्छा अनु, अगर एंटीरियर था, एंटीरियर हाइलॉइड मेम्ब्रेन, तो वो आपका विट्रस का हाइलॉइड मेम्ब्रेन है ना, तो दैट मीन्स एनीथिंग विच इज, आई टोल्ड यू वेरी क्लियरली, आई थिंक दिस इज एब्सोल्युटली क्लियर नाउ ना. ठीक है? इक्वेटोरियल और एंटीरियर के बीच होता है कैनाल ऑफ हैनोवर, और पीछे होगा हाइलॉइड मेम्ब्रेन में जो हाइलॉइड जोन्यूल्स एंड द पोस्टीरियर लिम्ब, दैट इज योर कैनाल ऑफ पेटिट. जस्ट रिमेंबर दैट. Right. So this is, I think the answer there was already marked. This is what I am listening in the question paper. There was something that answers were marked and so on. So whatever it is, this was your canal of Petit. Then, of course, rest of the options are not confusing. And Eggers line and all are all in the area of the Vigus ligament, if that is being also discussed as one of the options. So we are getting many versions of the question. So I am covering all the versions. अच्छा, हाफ आंसर वॉज विजिबल. चल ठीक है, कुछ तो काम चल गया ना हमारा, राइट? ओके, शुड वी गो टू द नेक्स्ट क्वेश्चन नाउ? सो दिस इज इट. अच्छा, ऑल ऑफ यू जस्ट लिसन टू मी. देयर इज नो नीड टू गेट सो डिसहार्टेंड एंड इन पैनिक बिकॉज ऑफ दिस वन क्वेश्चन, क्योंकि व्हेन देयर इज अ सरप्राइज, इट इज सरप्राइज फॉर ईच एंड एवरी स्टूडेंट. सो इवन द, सो यू हैव टू जस्ट अंडरस्टैंड दिस, दैट देयर इज नो नीड टू गेट डीमोरलाइज्ड अबाउट इट. ठीक है? वो सबके लिए सरप्राइज था. इट्स अ पार्ट ऑफ द गेम. Somebody answered, somebody did not answer. ठीक है, मस्त रहो. Okay, so no worries. So अभी तक कहाँ ophtha difficult है? This was one surprise which was for all. Indirect gonial lenses we all discussed in the lectures. This is nothing new for you all. See, I'm showing the pics also for you as a proof. And here also phenylephrine test has been discussed in the lecture. So abhi tak I think they should not panic. Let's see the next one. So I generally don't like my students to get panicked. Please, I'm here to encourage. There is nothing difficult when we are here. Okay, we come to this one. Now this is also a question I really feel why they have asked you in this way. So what is this question all about? So this question says that identify the correct sequence of staining in dry eyes. It is always going to be debatable. The examiner can only tell what he was thinking when he was asking. Why? See, when you talk about these three stains, any drying in the eye will start as a conjunctival xerosis, then going to the corneal xerosis. Okay? Now, the dyes for the dry eye are lysamine green and rose bengal because these two are staining dead cells and mucus. Take. Whereas fluorescein is generally staining your ulcer area, that is your epithelial defects, right? And live cells. Okay. Now, rose bengal being a very strong irritant, and sometimes it is not even considered a vital stain, it is considered it damages the living cells. So we were very clear कि चलो ठीक है दोनों overlapping है, both are for dry eye, so we can put rose bengal in the last. But the point here is, my point here is, there are two facts that you should remember. Most commonly used stain. If I have to very quickly in my practical purposes check what is the dry eye situation, I will do a BUT test, I will put fluorescein. If I am doing a quick test of the corneal epithelial defects, I have to put fluorescein. So fluorescein is one of the most common dye to be used. But this is not asked. The question is correct sequence of staining. If I take this question this way, that it is asking कि dry eye में sequence of staining क्या होगी? So it will start from conjunctival and then go to the corneal defects, na? So now it is debatable. What was in the mind when the examiner was asking this? So if I take these words, correct sequence of staining, I am going to answer, okay, first should be lysamine, right? Then it can be fluorescein, and third I will, rose bengal being very less used now, so I can just mention rose bengal at the last. So according to me, it should be first lysamine, then fluorescein, and then why? Because it says correct sequence of staining, means sequence in the disease. Sequence in the disease is from conjunctiva, then corneal defects. A severe dry eye will affect the cornea. But again, I am giving you another fact that most commonly used dye even for this dry eye becomes fluorescein because it can be used in the BUT test and assessing the cornea. ठीक है? So ये दोनों ही important facts and both are correct. Both the facts are correct. ठीक है? But I think we should answer this way. Because it is saying correct, if these were the words, if these were the words of the question, correct sequence of staining in dry eye. Right? Any problem here? Nobody is speaking about this staining part. ठीक है? आगे बढ़े? Okay. So we come to, again, this is all discussed in your lectures. So it is again a simple question, but of course this is, I would go with you all, it is very confusing question here. But again, it is confusing for all the students. So we will not worry. होता है. Okay, we come to the next one. Earliest change. Now see, there are two versions of this question I have got. First version is this one. I will discuss both the versions. First version says that what is the earliest change in glaucoma on perimetry? ठीक है? यही बोल रहा है ना? Earliest change in, please do you realize something? Earliest change. First visual field defect is of course that is central or paracentral scotoma in Jerem's area, which is very much explained in detail in all the lectures and in my classes. है ना? So it is paracentral scotoma in Jerem. But wait a minute. It is not first visual field defect that it is asking. ठीक है? So if it says first visual field change, यही बोल रहा है ना? So first visual field change अगर पूछता है, it is not actually a defect here, it may be a change. You can answer isopter contraction. ठीक है? So do you realize, and which is Jerem's area? Area corresponding to arcuate fibers. We have discussed this. है ना? It is nothing but area corresponding to arcuate fibers. So now you got it? What I am saying? Look at the 4 options that I've got here. I don't know, were these the options? Okay, Anu. Then I think this is the version that you are discussing. If this was not, of course, इसमें तो earliest change बड़ा clear cut हो गया. Complete loss, tunnel vision defect, complete vision loss. It is all end stage, so we can mark this because it's a change. It is written, not defect. But actually, first visual field defect is, of course, in Jerem's area. We will never forget this. अब आ जाओ अनु, the version that you are talking, I have put it here. यही था. Which of the following is true about glaucoma? Early and specific feature. This is, of course, not isopter contraction. It is paracentral scotoma in Jerem's area. So Anu, then this becomes a wrong statement. In static perimetry, the intensity of the stimulus is kept constant while it is moved. There is no movement in static perimetry. We have learned so much in detail about Humphrey field analyzer, automated perimetry, where there are multiple stimulus, and in a particular background we are just trying to see whether that patient can catch that stimulus in this background or not, right? So this again becomes a wrong statement. Kinetic perimetry is best for monitoring visual field changes. No, best is always static. So this again becomes your wrong statement. Now when you say this one, please listen to this statement also. Visual field defect to be associated with glaucoma if it is associated with optic nerve changes. You all should know this, that when there is an optic nerve damage, it has to be a substantial damage, then it shows as visual field defect, then it shows as cupping of the disc and changes. So I think among the 4, this seems to be a more sensible option. So if this was the version, we should be marking this as the answer. Okay, Anu. Then I think, then this becomes wrong. Isopter contraction is absolutely wrong. It is not specific. You can see in other conditions. Or वैसे भी I have explained you so many times there कि isopter contraction is not a usual perimetry finding. Usual perimetry finding से मेरा मतलब normal the perimetry target size should be 5 millimeter. Particular in when you are charting and trying to search isopter contraction, very small pupil size, particular illumination, where very small target size of 2 millimeter is used, just trying to catch hold of any earliest change. समझ आया? तो वो चीज जो है you can see in other conditions also, and it is not pathognomic for only glaucoma, and we never consider it as a earliest visual field defect. So this becomes wrong. And in static of course, I think now it is clear, Anu? ठीक है अब? चलो. I think so. This is again I'm showing here that everything is discussed in the class, so it was absolutely not a difficult question. You just needed to use your presence of mind. Okay, we come to this was another question which I got for one of the students, that what is the ratio of eye movement to head movement in your vestibulo-ocular reflex? So was this the question, all of you? Did you all come across this question? See, vestibulo-ocular reflex has been discussed in the class. We in the lectures, what is the other name? We also call it doll's eye reflex. Right? So vestibulo-ocular reflex, मेरे ख्याल से जैसे KF ring was very favorite in the INI CET for a few years. Now it is VOR. Because last time I think they've asked you about what are the nerves involved in the vestibulo-ocular. So what are the nerves involved in the doll's eye reflex? That was earlier question. And now it is asking you that what is the ratio of eye movement to head movement in VOR. So think yourself, when you turn the head, the eye moves. It is always equal and opposite in amplitude. We call it, that is, this ratio is called VOR gain, and the answer is 1. Okay, so we'll answer 1. Okay, and I will also discuss that previous question they have asked you, what are the nerves involved in the vestibulo-ocular reflex? So you should know how from the semicircular canals, vestibular nucleus, 8th nerve, then 6th nerve, and then it goes to the 3rd nerve, and therefore there is the eye movement. Medial rectus, lateral rectus are involved. The contralateral lateral rectus, same side medial rectus. Okay? So what are the nerves involved? Easy to learn. 8th, 6th and 3rd. Right. So this was earlier question of VOR. So this is a very favorite topic here in the exam now these days. KF ring era is gone now. Huh? Okay. So this was the answer. Yanu, did you get this question? Chandra is saying yes. This was the question. Okay. Then we come to this one. This is, I don't know whether we can call it an ophthalmology question or not, but it came to me. So you know this is mainly what is happening in the medial side of the nose. This is the nasociliary block. right? In eye related, I would just say that in dacryocysto, rhinostomy, when we are giving the infiltration, local infiltration, we are trying to involve all these nerves, infratrochlear, infraorbital, antiethmoidal, and nasociliary. Okay, so these are the questions. I will very quickly go to the answers. Here it is nasociliary block. Here the ratio is 1. Okay. Here we will answer C option. This is associated with only if associated with optic nerve head changes. I have given you a new information here. First visual field defect is parasyntoscotoma in Jerum's area. First visual field change may be considered isopter contraction, but depends on the different options. Then we talk about the sequence. Because it is sequence of staining, it will not directly involve the cornea first. We have to keep that in mind. Yes, and of course this is a new anatomical thing that we have to learn now. What is Hanover and what is Petit's canal, right? So how this this is in form of a fork. So here the answer was canal of Petit. Now indirect and direct, we have learned the different names here, right? And we know what is direct and what is indirect, correct? So here what is the answer? Cope and Richards. Both are direct. And here of course this is again stands the confusion whether it was not blanched or blanched, but I've explained you how you will answer related to this question. Right? So at the last, I would just end. Anything you want to ask, you can ask. Otherwise, I'll just end with a very small thought for the day here. And let's think about it. I quickly wrote this for you. Live life one at a time. So it's the end. The exam is over. We will not think about the result. We are going to enjoy ourselves. Party hard. Relax. This is the time to breathe and relax. Okay? No worries. You remember? I told you before the exam, no doubts, no fears. Now I am again telling you, no doubts, no worries. जो होगा हो गया, ये कर्म कर लिया, अब जो आएगा फल देखा जाए, ठीक है? So just enjoy these days and relax. Don't worry about it. Yes, now the questions are easy. Thank you, Chandra. This is where I'm very happy to hear that. बहुत कुछ difficult नहीं था. 90% से भी ज़्यादा चीजें we have discussed in the lectures. Don't worry, and please always remember, if it is a surprise for you, for majority it is a surprise. So why to think so much about it? Okay? Okay. So should we end here? Thank you so much. Stay blessed and keep smiling. I'm waiting for a minute if there is any question. And of course, you all know you can directly contact me through DM me, Insta, Messenger, or you can mail me, right? Whatever. Generally, I think now these days it's easier because we follow this Insta and all. So too many sources, then I will miss. Huh? So just DM me on Insta. Okay. Chalo, theek hai. Thank you so much. Thank you. Thank you. Stay blessed. No questions. I'm ending now.